So good morning again. We're going to have Dr. Tank, our hospital president, kick us off here this morning.
Thank you. Thank you, Lisa. Good morning, everyone, and welcome to Hackensack University Medical Center's Trauma Informed Care and Health Equity Conference, focusing on the critical intersection of TIC and the health equity within our NICU. I'm Dr. Lisa Tank. I'm the President and Chief Hospital Executive at Hackensack University Medical Center at Hackensack Meridian Health. It's an honor to open this important conference, and Dr. Island, thank you for inviting me to do so. The NICU, as you all know, is a unique environment for families. It represents a time of immense joy, but at the same time, there's vulnerability, hope, and often significant stress. Infants facing complex medical challenges require specialized intensive care, and at Hackensack, we strive to provide that. But we provide it in multidisciplinary care teams who spend countless hours and innumerable skills shepherding the patients and families along their NICU journey. And the goal is really to alleviate anxieties, to support families and support parents as they make these complex decisions. It's within that context that the principles of trauma-informed care and health equity become not just beneficial, but essential. We all realized during COVID how critical this was. This conference is built on the understanding that we aim to create a more supportive and a healing environment for all, especially our tiniest patients and their families, and most importantly, having that bond between the dedicated team and the families and the parents. So as the first hospital in the nation to achieve the Joint Commission Advanced Certification in Perinatal Care, which recognizes our commitment to providing high-quality, comprehensive care for mothers and newborns, as well as the first hospital to receive the Joint Commission Gold Seal, approval for advanced certification for healthcare equity. This recognition is evidence of our commitment at HUMC to providing equitable care and reducing health disparities within our community. We are honored to host this event and our gratitude for attending this. Over the course of the morning, we will delve into practical tools and strategies for building strong, trusting relationships between patients, parents, our care team, and the broader community. We explore how to mitigate physical, emotional, and social stressors within the NICU environment and foster a culture of resilience and healing. I'm incredibly proud and privileged to work at Hackensack amongst these teams and to champion the trauma-informed care and health equity with Dr. Island. This conference represents our commitment to providing the highest quality, compassionate care with empathy for every infant and family that we serve and the community we serve. We reflect the community we serve in our multidisciplinary teams. I'm confident that the insight and skills shared here will empower us to create a more just, healing environment for our NICU experience for everyone. Thank you again, and I wish you an engaging conference and a great launch to a very important conversation. Thank you so much for having me. Dr. Island.
Thank you, Dr. Tank. Again, welcome everyone to our program today. I am so excited to be here. Dr. Tank and the leadership of the hospital has provided unwavering support of our team in the care of our patients and their families. The idea for this conference grew out of an acute awareness of the changes occurring across the world and certainly across our nation in the field of newborn medicine and neonatology. Due to advances in technology and medicine, our patients are more complex than ever before. The resuscitation of the 22-week preterm is occurring at many centers. Similarly, diagnoses which decades ago were considered life-limiting for patients, families, and the care team are now journeys that are possible for all of us. With these advances, of course, come greater challenges. traumas, and with limited resources, often widening disparities in health outcome. Today, I am honored and privileged to have been able to gather leaders in the field of trauma-informed care and health equity to help impart tools to all of us to be able to meet the challenges that are brought about by the changing landscape in neonatology. I want to go over a few housekeeping issues before we kick off our conference. First of all, communication with the panelists, specifically for our Q&A sessions, will occur through the webinar Q&A panel. So enter any questions that you have into the Q&A panel, and then our moderators for the sessions will make sure to get those to the panelists for answers. Certainly, we have a limited program today. I'm sure we could talk about this for hours or even days on end. So we'll have to limit the Q&A sessions in most cases to about 15 minutes, but we'll be looking for commonalities and questions so that common themes and common concerns will be addressed. Certainly, our panel will provide a recording of today's sessions and the ability to reach out to us through emails that you received in your registration for further discussion. The other exciting part of this session today is the ability to really not just learn today, but to make a difference in the care of your patients and families moving forward. So we invite participants to take on and participate in a quality improvement initiative based on the principles of trauma-informed care and/or health equity. So wherever you are at your centers, there are a multitude of us in this battle to provide care to our patients. We would encourage you to take on one small piece of your environment that you think could be changed to better the lives of your patients, the families, and also the care team. Because what's important today is also realizing that we as caregivers also undergo trauma as we're navigating through these journeys with our patients. So you have the opportunity to register for facilitated quality improvement sessions. They will be 1 hour monthly sessions occurring March, April, and May, and will culminate in a summit in June. At the end of the program today, more of those details will be provided, so please stay tuned for that. With that, I'd like to also introduce our moderators who will be joining me today. So I am privileged to be joined by two of our care teams here at Hackensack. We have the experience of two nurses who have over 25 years nursing experience in the NICU. The first is Terry Spirito, who is here with us at Hackensack. She's currently serving as our NICU nurse educator. She chairs multiple of our Hackensack Meridian shared governance nursing councils and is a member of our magnet team. Also joining me today to moderate sessions is Maggie Campestri, who again has over 25 years experience here at Hackensack. She's been a charge nurse in our NICU for the past 15 years. She's an active member of our unit-based council, our unit-based infection and CLABSI prevention team. She is the co-chair of our NICU bereavement committee and presenter at our annual bereavement conference. She has mentored countless nurses within our NICU, and I couldn't be more proud to welcome them today to this session. And with that, I'll turn it over to them.
Good morning. My name is Terry Spirito.
I'm Maggie Campestri.
Yeah, and we have the honor to introduce our first speaker of the day, Mary Coughlin. So Maggie, take it away.
Thank you. It's my pleasure to introduce Mary Coughlin. She's a globally recognized expert and pioneer in trauma-informed developmental care. As the president and founder of Caring Essentials Collaborative, Mary leads the charge in transforming the care of the tiniest and most vulnerable patients in the NICU. With over 35 years of clinical expertise as a neonatal nurse and neonatal nurse practitioner, Mary has dedicated her career to advancing compassionate, evidence-based practices. Her innovative buffer framework, which emphasizes belonging, understanding, forgiveness, frameworks, equity, and respect, empowers healthcare professionals to reawaken their shared humanity while fostering deep connections with the babies and the families that they serve. A sought-after speaker, author, and educator, Mary has touched the lives of countless clinicians, helping them integrate trauma-informed care principles into their everyday practice. Through her leadership, Mary continues to inspire a new era of neonatal care that honors both science and the soul. Thank you.
On a personal note, in 2017 at Hackensack University Medical Center, we started on a journey to improve the care that we provide in our NICU to babies born less than 30 weeks. Mary Coughlin's book, Trauma-Informed Care in the NICU, was instrumental for our team of multidisciplinary providers in developing guidelines to specialize and improve our care for these small babies. The concept of trauma-informed care was new to many of us at the time, but Mary's research helped us think differently about the long-term impact of the care that we provide in our unit. As we furthered our journey, in 2019, we applied for the Joint Commission Disease-Specific Certification in Prematurity, and Mary Coughlin's webinar, Trauma-Informed Age-Appropriate Care, a New Paradigm for the NICU, was an instrumental part of the training that we provided to all team members in our unit. We became the first hospital in New Jersey and only the 7th in the nation to earn the Prematurity DSC from Joint Commission. And her webinar continues to be a part of the ongoing education that's provided to all new nurses coming into our NICU at HUMC. Maggie and I were two of the original instructors for this class for the care of the small baby. We have both watched her webinar many, many times, and each time we see it, it impacts us in the same way. Over the past 8 years, Mary's research has helped us reevaluate and improve our quality of care for small babies. In fact, as an adjunct clinical nursing instructor, I assign it to my students every semester so that they too can think about the care that they are providing to infants and children during a long-term hospitalization. So on behalf of Maggie and I and our entire NICU here at Hackensack, it's truly an honor to introduce Mary Coughlin.
Oh boy. Thank you so very much for that incredible introduction. I'm totally overwhelmed by your kind words and super honored to have the opportunity to speak with you guys today about a topic that is incredibly critical and relevant. So let me just get myself together here and whew. I usually have a little stress response when I do talks, but that those very kind words have really touched my heart, really. Thank you so very much, you guys. Okay, so here we are, the case for establishing and maintaining trauma-informed care in the NICU. My disclosures are I'm the president and founder of Caring Essentials, and I'm also on the executive council for the Family-Centered Care Task Force. And at the very end of my presentation, I have a little QR code on the slide where I invite you to consider joining the Family-Centered Care Task Force. And I also have a second QR code for a little workbook that kind of dives a little bit more into the buffer framework. These are my learning intentions. I want to touch upon some of the impact of early life adversity on newborn development, talk about, the intersection of trauma-informed care and excellence, as well as health equity, and talk about, again, some actionable strategies. And I love that that's the real framework behind this conference, is really helping you guys walk away with some tangible strategies that you can implement at on your next shift, right? So why trauma-informed care? And before I really dive too deep into this, I just want to check in with you guys. How many of you folks on this webinar started out life as a baby? I'm going to guess it's most of you guys. And the reason why I emphasize this, get a little bit of a smile out of you guys, but I think for me at least, when I started diving into this work of trauma-informed care, I always viewed it as for somebody else, right? I was showing up trauma-informed for someone else. And although that, to me, I think that's a great place to start, what I've learned over the evolution of my developmental trajectory in this work is that it really is about a shared human experience. And until we can really make those connections, which don't happen overnight, so don't pressure yourself, it's going to be really hard to fully lean into what it is to be trauma-informed. Use your own life story as a touchstone to help you make those connections with others. And as Dr. Island mentioned as well at the beginning, I mean, we are doing more and more miraculous things in neonatology. We are saving the lives of younger and younger individuals. And with that comes a bigger burden for us to be really mindful about how we are showing up to these experiences of these babies, of these families. And the technical stuff is wicked important, and I totally support survival. I really, really do. But I think what we need to do is come back to marrying or merging our focus on survival with also an emphasis on thriving and helping these individuals flourish and helping them cultivate resilience. And in doing that, we have to be mindful of what this experience does to us. Now, as I mentioned, I asked you guys about, did y'all start out as babies? And I'm guessing you said yes. And so let's just see, what do we know about the embedding of stress on newborns? All right, we can say the word neonatal too. And Dr. Heideley Zals was the one that really kind of got me shifting my lexicon and trying to move away from neonatal, which is kind of hard to do, to newborn, because newborn kind of has more of a humanity feel to it. It's less medicalized. And so I want you to, don't stress yourself out, but to just really start looking at the words that we use and appreciate that the words that we use really drive a lot of our behaviors and our attitudes about situations. So let's look at this as the newborn stress embedding model. This was first published by Marlies Nist et al. Back in 2019, and we have reams of research, and I will touch upon that in a little bit more detail in the next slide, that helps us really understand how individuals, brand new human beings, are influenced by their environment. The American Academy of Pediatrics back in 2012 actually issued what they call the Eco-Biodevelopmental Framework, which they described as the new science for pediatrics, understanding that the ecology of a developing individual, both relational and environmental, physical space, influenced their biology. And that biological influence then impacts the developmental trajectory. And we know that stress, at least right now what we know, impacts all of these different biological systems: autonomic nervous system functioning, gene expression, immune integrity, HPA axis, and also influences how individuals' brains are developed at every single level, which then informs how they move through the world. If you think about Erik Erikson's psychosocial stages of development, that first year of life is all about trust versus mistrust, and the life virtue is hope. And so when an individual experiences overwhelming fear, overwhelming stress, overwhelm, period, that influences how their brains are going to adapt to the situation and cope. The downside of that adaptation, particularly when brains are in a rapid stage of growth and development, is, you remember Hebb's law, right? Neurons that fire together wire together. Those adaptations for the short-term experience actually become maladaptive over time. But we don't pay a lot of attention to that because we're just learning about that. And so we need to kind of put that little bee in our bonnet and understand that, yes, this is overwhelming and we're going to do everything we can to mitigate and manage your experience, but the work is not done on discharge, and we need to continue to support these individuals and help them shift their perception of the world through their experience with us and through their experience post-discharge with their family and the community at large. And so I know this is a bit of an eye chat, but I really was trying to be conservative and not throw too much science at you through a series of slides, so I just threw it all on the one slide. But it is unbelievable the amount of research we now have available specific to newborns, and even more specifically to premature individuals, looking at epigenetic modifications. There's actually some really interesting studies that help us better understand how these epigenetic modifications during the neonatal period actually have significant implications for mental health outcomes as early as toddlerhood into adolescence and of course adulthood. So we know that there's epigenetic modifications in the face of toxic stress, and that's what these individuals experience. We also know that they experience shortening of their telomeres. Now, I don't think about a telomere every day of the week, and so I usually have to touchstone back and figure out what the heck do those things do now? And I think of them as those caps that you put on the bottom of your dining room chair to keep them from scuffing up the floor, or like on the shoelace, that little plastic thing. And what happens when they get shortened prematurely is that the body has less to draw upon over the developmental trajectory. And so kind of, compacting this clinical relevance, individuals that have shortened telomeres coming out of the gate actually tend to have a shortened lifespan as well then. Because, a lot of these changes influence their or increase their vulnerability for adult morbidity. So that's some of the epigenetic modifications. Brain development is wicked fascinating. And this image that I have here, for me, really helps me understand what's actually happening internally for these individuals. So we know that the brain develops from the bottom up and the inside out. And the first part of the brain to develop is the brainstem, and because it's survival, right? No sense having a cortex if you're not going to survive. So that brainstem plays a very important role. The next layer is that limbic system, the relational, the emotional piece of our anatomy, of our neuroanatomy. And then lastly is the neocortex. So in your everyday life, when you show up to a situation, and I want you to think about a baby or think about a parent, or you could even think about yourself. When you first show up to a situation, I'll use myself. When I showed up to this situation, right, I always get a little bit nervous before a webinar. I don't want to say anything bad, but stuff can happen. And so first I'm stressed. And so I'm worried about, is everything going to work out fine and all this other kind of stuff. I'm not really paying attention to anything else until I know I'm going to be safe from a technical perspective. Then my limbic system kind of gets activated. Then I'm like, well, gosh, I hope they like me. I hope this goes really well. And then after that beautiful introduction, I was totally feeling big love. And so then my neocortex, the cortical part of my brain, comes online. And now I'm about to dump everything that's in my brain all over you guys for the next 40 minutes or so. But had I not been able to move from my overwhelm of fear about the tech, I would never have gotten to this place. And so think about some of the, I think about the parents, when they come in, and you might be saying the same thing to them for 4 nights in a row and thinking, there's something wrong with them. Yeah, there is. They're overwhelmed. They're terrified. They are experiencing traumatic stress. And so anything else is irrelevant. It's not going to penetrate because they're in that state of overwhelm. So that same phenomenon impacts brain development of the children as well, of the babies as well, and it impacts default network patterns and salient patterns that really become a backdrop of how these individuals move through the world. We know that the autonomic nervous system is again linked to our survival, and if my stress response isn't going to keep me safe, my stress system actually becomes even more sensitive. So I become even more stress intolerant because my body is trying to figure out, how do we keep her safe? Well, she's obviously not responding quick enough. She's not being vigilant enough. And so over time, I become super hyper vigilant, and that response becomes maladaptive over time. I hope that's making some sense. And then this more recent research I guess it's kind of in the same time span as the epigenetics, but this mitochondria thing. And folks are doing even more and more research about this. I mean, again, right up there with telomeres, the mitochondria, the powerhouse of the cell. But when we start thinking about, when I am in a state of stress, I am burning energy, I am burning calories. And we know that these individuals already come at a caloric deficit. They're a big energy deficit at birth due to a myriad of, factors, prematurity, severity of illness, all this other kind of stuff. And then I'm adding the stress on it. And sometimes, I used to think, well, they don't look stressed. They're just kind of laying there and chilling. We oftentimes we confuse that passivity with acceptance of the situation. And actually what's happening now is these children, because the stress is so overwhelming, they're dissociating from their reality, and that's churning through a lot of calories. And so that would have been really nice to know as a nurse practitioner when I'm, calculating the TPN, I'm only thinking about how much to put in. I'm not really thinking about how much is being burned. And so, kind of thinking about these things, and we get indirect data about the benefits, particularly, let's say, about growth and early discharge through skin-to-skin care. One super simple trauma-informed intervention that has, a ripple effect on how it positively impacts the baby's developmental trajectory, physically, psychologically, emotionally, and socially. There's so much more, but I just really wanted to kind of touch upon this. And I want you to make a connection to your own lived experience. We know from the Adverse Childhood Experience study that the majority of people on the planet have had at least one adverse childhood experience, and that's affected your developmental trajectory. The goal, it's not about eliminating trauma. We can't eliminate trauma, but we can mitigate it, particularly when we know that it's actually happening on our watch. And it's not just the babies, right? It's the families as well. And we're going to hear so much more from that family experience from some of my very esteemed faculty peers here on the conference. But families are impacted overwhelmingly. And I can speak to this a little bit because my baby daughter is also a former NICU mom. And I know the dates on this little video that I just popped up, and I hope I hit the right button here. Actually, I'm going to stop the share for just a second because I'm not 100% sure I hit the right button to do the share. I did. Oh, how smart am I? But little Avery is alive. That was just one of those videos that your iPhone collects. And when I was putting together this talk, it felt really relevant. So I hope you'll indulge me as I share this little brief video of his and my daughter's experience. Now, as much as I love that video so much, it does strike a chord in my heart every time I watch it. And he's going to be 2. Actually, tomorrow is his birthday, his 2-year birthday. There's so much going on behind the experience of being a parent in the NICU that meets the eye. There's this really powerful quote that from Lothian that says, "Human beings have an amazing capacity to adapt and make a go of things no matter how difficult. But that should not be rationale for continuing practices and language that are roadblocks for women and their babies as they fall in love." My daughter literally was getting all annoyed at me. We literally, what do you call it? We squatted. This hospital was not ready for for us for sure. And they did not have living in space for parents, and that never even crossed my mind to even ask that question. It was like, we're here, we're staying until this little guy goes home. I'm sure if it went on more than 2 weeks, because he was in the hospital for 2 weeks, he had a surgical situation, they would have said something to us. But it was overwhelming to see the strength of my daughter, and also the vulnerability of her as she navigated this situation. I knew my grandson was going to be okay because of the tremendous love that she has for him. And I love him as well, but my job there was to care for my baby, my daughter. And watching her navigate the experience, and watching a healthcare experience that I'd never seen through that lens unfold in ways that brought me great pride and joy, but also broke my heart in other situations. We can do better. We need to do better. And the only way I think that we can really do better is really reevaluating these experiences through our human lens, seeing what is unfolding as if it were unfolding to us or a family member for us. This is not an othering job, particularly nursing. Nursing, according to Florence Nightingale, we're admonished to manage the human experience of disease. The disease is wicked sexy and exciting and challenging and stimulating and all that kind of stuff. And I'm an adrenaline junkie too. And I missed lots of opportunities to really lean into my oath, my covenant to the patients and families I served, because I was so hypnotized by the tech and all that kind of stuff. We can marry the two together. We can do both together. It's not an either or situation. And so that brings me to now really understanding this idea of trauma and its impact on us. We bear witness to one of the most horrific things that can happen to a family. The birth of a baby is a joyous moment, but when it is overshadowed by a life and death situation, when it is overshadowed by a disempowerment and guilt and all of the overwhelm and negative self-perceptions that unfold on behalf of the family, that takes a toll on us, particularly when we don't acknowledge it, when we don't embrace it, when we don't debrief about it. And we pretend this is just part of my job. That's how I was acculturated into my professional practice. Don't get too close. Don't get too personal. You have to be the professional. But again, they're not mutually exclusive. I can be compassionate and loving and human and professional all at the same time. As can you, and as you do. And we have to help each other navigate this. Sometimes, I just need to tap out, and I need my colleague to, can you help me? I just need to go get a cup of tea or walk up the stairs or do something to just try and help reset myself in the moment. There's a lot of work I need to do outside and off shift so that I can prepare myself to show up to the suffering of others with an open, understanding, and compassionate heart. I know it's wicked hard work. I do, and it's a process and a journey. But just being part of this conference and listening to the beautiful work that you've already done here in the NICU, you're on the road. You've got this, and there's so many other ways to really lean in and expand the fullest capabilities of who you are as a healer in this work. Touching back to, did everyone start out as a baby, right? And then looking at my daughter's experience in the NICU, that wasn't the only tough thing that was happening in her life. That's not the only tough thing that happens in anyone's life on any day. We live in a traumatic world. And yes, we have acute epochs of trauma that are happening in our face, but it's always on this backdrop of systemic trauma, structural trauma that oftentimes eludes us, particularly, myself, here I am as a white woman, and never really understanding what it meant to be privileged, to have the privilege of being white in this world, and really metabolizing that, trying to come to peace and come to alignment with that reality, so that that wisdom can inform me to open up my heart even more, to be more compassionate, to be more understanding, to be curious. Because the things that throw me over the edge may not throw you over the edge, but that doesn't mean that my stuff's more important than your stuff. It's really understanding the big picture here. And there's lots of moving parts, and I don't want to overwhelm you. I got a wicked awesome bib at the end of these slides. And so I invite you to check this out, because there are layers. Like myself, for this journey though, all right, I started out small. That's how you eat the elephant, one bite at a time. I just looked at this paradigm focused on the baby. And then, gradually, as I became more solid and confident in understanding that, then I could, more readily embrace the family elements of this. And then, then myself, and then realizing myself, I'm not just this slice of Mary who shows up to work. I'm multiple slices of a complex individual that, just like everybody else, trying to do the right thing. And that's the work of this, to really recognize that we're all on our own path, but we're all influenced by very similar things that impact our humanity and our humanness. And what's really wonderful, I mean, if you can look at it that way, is we're getting more and more validation. We're getting more and more information, so that we can truly understand how these adverse childhood experiences play out, and that it's not just this one discrete event. Oh, you survived childhood, woohoo, you're all set. You don't have to worry about another bad thing ever happening to you in your life. Didn't we all just come off of a global pandemic? And that hit everybody in just so many different ways. And so overwhelm, trauma, toxic stress, those are parts of the human experience. But a lot of those parts are man-made, and we can address those things. And that's the inequities piece. That's the racism, sexism, homophobia, xenophobia, all of those things that we can, when we open up our eyes and when we become more aware of our shared connectedness, we can really internalize that understanding and then have it translate out into how we show up to our work, how we better understand. And we don't have to know everything. You'll never know everything, right? But getting curious enough to ask the good questions, so that you can be of true service to those that you've been called to help, to journey with. And so, why trauma-informed care? It's because of all of that. This, I used to think of trauma-informed care. I was first introduced to it. I'm watching my time here, but I was first introduced to it, never heard of it before, when I was asked to step in as an interim nurse manager on an adolescent psych ward. And there was this lovely woman from the Department of Mental Health here in Massachusetts. And she said, oh, well, we want to, incorporate this trauma-informed care. I was like, yeah, sure, I'm game. Tell me what to do. And they, she starts explaining this to me. They're sending me to conferences, and I'm thinking, holy mackerel, why isn't this in the NICU? Because in the NICU, instead of it being a way of how we respond, I mean, and certainly it is to each other and to the parents and the families, but it can actually have a prevention perspective too, a prevention component when we look at caring for these little babies that are navigating this overwhelm, this toxic stress, this trauma experience. And the things that I can do to mitigate and manage that actually foster and cultivate resilience in these individuals and in these families. So it's a powerful tool that actually has impact beyond the NICU experience, post-discharge. These individuals learn that they can do hard things together, connected, with love, with support, with respect, all of the things. And so this idea really, it's a big shift. It's a paradigm shift. I remember being a nurse practitioner, it was kind of like, what's your chief complaint? Why are you here? That's the what's wrong with you kind of a perspective. And what's wrong with you? I will learn everything about your disease. But, when we approach people that way, we miss the humanness, right? I mean, if I get admitted to a med-surg floor for cholecystitis, I know they're going to do great care with my gallbladder, but they're in for a big surprise because my gallbladder is wrapped around by me. And so you have to get through me to get to my gallbladder. And I'm going to ask questions. I'm going to want to be seen. I'm going to want to be heard. I'm going to want to feel cared for. And so that's, that shifting paradigm to what's happened to you, really prioritizing and understanding the impact of this situation, and encounter that overwhelm with authentic compassion, with empathy, if it's appropriate. If I have a shared lived experience, or at least to acknowledge. I'm testifying that you're getting through this, and this is probably one of the worst things I've ever seen. God bless you, or whatever it is that feels right to you. What happened to you? But also to be mindful, right? That trauma is not it's not a life sentence. That's Peter Levine says that. He's one of these big world famous psychiatrists, psychologists. It's really seeing what this is happening to you. It's horrific. It's overwhelming. What's strong with you? Because I know deep down inside of you, you can navigate this. We can do this together. And helping people really feel seen in that is so wicked empowering. You'd be blown away that this operationalization of trauma-informed care happens in the most subtle, beautiful ways. You're going to be so wicked happy once you really start diving into this. And I thought that this was a really powerful quote from the CDC, that adopting this approach of trauma-informed care, it's not accomplished through any single particular technique or checklist. It requires constant attention, caring awareness, sensitivity, and even a cultural change. It's about the being, not about the doing. And I hear many folks say, gee whiz, Mary, I'm already juggling 80 million things. How am I ever supposed to now? You want me to do trauma-informed care? Holy moly. It's not that kind of a thing. It's not about doing more. It's about being more of your best, most loving, expansive, compassionate self. It's really getting curious about, how's my current way of showing up, and how does that sit with my values? How does that sit with the needs of my patients and their families? And what a wicked powerful quote here, right? I mean, once you label me, you negate me. The 24-weeker, the diaphragmatic hernia, the gallbladder, the difficult family. Once you label me, you don't see anything else. And my behavior when I show up to an overwhelming, traumatic, frightening situation, that's my default setting. I'm showing up because I am scared. You're not seeing my best self. In any critical situation, you're very rarely, if ever, seeing the best version of that individual. And you need to show up and understand that. I remember my colleagues, why does this kid always lose his IV when I come on shift? Oh, because he's been just waiting for you to get back at you. I mean, come on, be serious. People, we have to, but in order to have that sense of self-awareness, we have to prepare ourselves, right? We have to do the work. We have to metabolize our own story. We have to build our own personal wholeness, cultivate healing intention. Those are the things that we need to do so that we can bring our best self to the work that we do in an incredibly overwhelming, technically oriented, fast-paced environment. And yes, we're short-staffed. We've got, list all of the struggles that we have. But this is a moral and ethical imperative. And if we can begin to do the work, I love how Dr. Allen said at the beginning about the quality improvement piece of this, because we need more data to draw the connections between compassionate, caring work and efficiencies and positive patient outcomes and staff retention and satisfaction and all of those things. And so for me, trying to get my head around this, and I'm not trying to say I've got it all nailed, but I'm working on it. I've kind of created this little mandala, I guess, and in the middle is the baby and the family, kind of abstractly designed. And those words close to the baby, those are the attributes of a trauma-informed professional. It's about being knowledgeable, but it's all ways of knowing. It's not just empirical knowledge, which is generally like, star of the day, but it's knowledge about, it's our personal knowing, it's our spiritual knowing, it's our technical knowing. It's all the different ways that we know. It's listening to our gut and respecting that intuitive knowing from our colleagues and expecting our colleagues to trust ours as well. It's cultivating healing intention, practicing loving kindness, developing our spiritual wisdom, or whatever corollary aligns with your own beliefs. It's building personal wholeness, getting exercise, eating right, getting good sleep. And those first three attributes right there, when you really start to build that foundation, it then gives you the courage to stand up against inequities and advocate fiercely and lovingly for what is right, being an intentional role model and mentor for those that are coming after you, and maybe those that are before you, right? It's practicing scholarship, and you can do it in big and small ways, right? Go ahead, do research, write the papers, or maybe start crafting some lunch and learns to pass on the knowledge that you're accumulating and curating with others, and empower them to do the same as a leader for change. And these little petals around the side, that's a mix of the core measures for developmental care and along with the principles of a trauma-informed paradigm. The core measures are healing environment, activities of daily living, compassionate collaborative relationships, pain and stress management and assessment, protecting sleep, grounded by these principles of safety, trust and transparency, healthy relationships and interactions, empowerment, voice and choice, equity, anti-bias, and cultural and gender affirmation. All of these things, there's a lot to do, but it's also part of who you are as a human being. All of these moving parts are already there. They're already moving in your sphere, in your biology, in how you see who you are. You just need to tap into them. And for me, the foundation for this is really in this buffer acronym. And it kind of evolved from really listening to what the Academy and other wise people were saying about being the buffering. The trauma-informed care isn't about summing up the suffering, but building the buffering, empowering parents to stand in their role as that parent and being that fierce advocate for their baby, trying to learn and build their own confidence and competence, right? That's what building the buffer is. And so think about like just the simple thought of what it feels like to belong in your team, to belong in your family, to belong in your community, or belong in any kind of social setting, not fitting in, because fitting in is different, but belonging. Belonging is imbued with a sense of safety and trust and healthy relationships and feeling seen. Understanding, really, attuning to the needs of others based on the practice that I've been doing, attuning to my own needs. What does it feel like to be frightened? What does it feel like to be marginalized? What does it feel like to be hungry? Practicing forgiveness for self first, right? I mean, we make mistakes, we're human beings. And letting go of that, forgiving ourselves actually opens up our heart so that we are better able to forgive others. It doesn't happen overnight, it's work. We work within frameworks. This is all evidence-based. Use that as a touchstone. I'm not doing this just willy-nilly. I know that a sense of belonging, it gives an individual a sense of safety, a sense of being seen, and all those kinds of things. Practicing that equanimity, being able to have that sense of composure, and realizing when you don't, and maybe you have to tap out, and somebody else needs to come in so that you can rebuild and refill up your cup. Because we navigate overwhelming situations, difficult situations. When people are frightened, what did I say earlier? They are not showing you their best. They're showing you they're most scared. And their most scared may be yelling at you, maybe saying mean things to you, maybe dismissive of you. you have to show up with love. And in order to do that, because it's hard, when somebody's yelling at you, you tend to react. But the buffer allows you to respond, not react, so that you can then respect the dignity and humanity of those that you're serving, because you're grounded by this framework. Children don't get traumatized because they're hurt. They get traumatized because they're alone with their hurt. The number one traumatic experience endured by newborn mammals across all species is maternal separation. Lock that into your heart and your brain. No matter what their behavioral expression is, no matter what they're looking at, or looking like rather, that is a biological reality. Their little bodies are being flooded with cortisol, catecholamines, inflammatory mediators, and they have no control over that. Babies do not see themselves as independent entities. They are biological dyads. They are in relation to, and usually up until about maybe 3 to 5 years of age. And so that disconnect, that disruption in that natural pattern of biology has physiologic and neurobiological consequences that we see maybe not played out in the NICU, because there's not a lot of tasks that are, babies have to, perform for us, but it plays out in toddlerhood, adolescence, and beyond. There was one quick a little side off the script here, a really interesting study that looked at over 6 million babies who had NICU experience, and they stratified these individuals according to their gestational age, and all of these individuals had increased risk for a myriad of adult morbidities like cardiovascular disease, cancer, metabolic syndrome, diabetes. But what was most significant was an increased risk in psychopathologies. Specifically, the leading cause of death was suicide. And so again, just the magnitude of the problem, but the magnitude of the opportunity when we adopt and embrace a trauma-informed paradigm. And so coming down to the home stretch here, I would love for you to just kind of take a second here and reflect on your own practice with loving patience and grace. And start to kind of examine, what is one small meaningful change I can commit to tomorrow? A small step. My mother-in-law says, an inch is a cinch, a yard is too hard. It's about the small steps. And that can be challenging for many of us who are wicked impatient and we want it all done yesterday. But be gracious with yourself. Buffer your own tendencies. And be kind and gracious. And you'll be amazed at what you discover about yourself. It's really an invitation to lead with your heart. And when we lead with our heart, we can rehumanize healthcare. Literally for everyone, the babies, the families, and ourselves. I just make the connection that trauma-informed care is about love. Love is all around us and in each and every one of us. It's like air, it's ubiquitous. We don't really see it, but what we need to understand is that without love, just like without air, we will die. When we take the time to notice ourselves and another, when we truly are present, we have the power to transform a moment in time into a timeless healing moment. Whoops, how do I get past that? And so this is my last slide, but I have to zip to the QR code. I'd love to you just jot down, what's your greatest insight from this session right now? Write it down while it's fresh, while all my words are still flurrying around in your head. And I'm going to advance to my last slide where I hope, oops, yep, I hit the URL there, sorry, here. And so this QR code on the right, I tried it on my screen, so you can actually do it through the screen. We'll bring you to the registration for the Family Centered Care Task Force. This is a free organization, and you get to join. I think they're now up to 2,000 people worldwide. NICU professionals and NICU parents, present and former, all working together to transform family-centered care in the NICU. And then the little QR code on the left, I put together this little nerd alert. A little toolkit that kind of dives a little bit more into what the buffer framework is really all about. Thank you so very much. I really appreciate this opportunity, and I'll stop sharing and try and stop talking.
Mary, thank you so much. Every time I hear you speak is a gift. I I take a jewel from your words, and think of the ways that I can apply it to the care that I have. I love that you speak about really essentially having grace for ourselves and for our families, realizing that none of us are showing up as our best selves when we're under this inordinate amount of stress. So thank you for that.
You're most welcome. Thank you.
Um, we're going to move along to our next speaker. I want to remind participants that they will be able to please put your questions in the chat. And during our Q&A session, we'll be able to, ask those of our panelists. And as I get ready to introduce our next speaker, I also will let you know we'll be sharing a disclosure slide during our session as well. But in general, our speakers don't have anything to disclose. So it gives me great pleasure to introduce our next speaker, Ms. Kimberly Novod, who I had the pleasure of meeting at a Vaughn conference last year, and she really changed my life. Kimberly is the founder and executive director of Saul's Light Foundation, a New Orleans-based nonprofit organization dedicated to addressing the unique social and emotional needs of Louisiana's neonatal intensive care unit and bereaved families. As an advocate for family-centered and equitable healthcare policies, Kimberly is most passionate about maternal mental health issues, prematurity, and infant loss in the Black community. In 2019, Kimberly was the recipient of the Millennial Changemaker Award and a New Orleans City Council proclamation for exceptional community service. The following year, she was appointed to the Healthy Moms, Healthy Babies Advisory Council by Louisiana Governor John Bel Edwards. And in 2021, Kimberly was recognized as a fearless driver by the Fearless Fund and MasterCard. She is a graduate of Xavier University of Louisiana and received a master's degree from Troy University. I am proud to call her additionally a SOAR, as she's a member of Delta Sigma Theta Sorority Incorporated. Please join me in welcoming Kimberly Novod. Thank you.
Thank you so much, Sora. Thank you for having me. I'm going to go ahead and share my screen. Let's see where. All right, so I hope that everyone can see my screen. Thank you so much for that generous introduction. It's a pleasure, truly, and an honor to be here, to be able to lend my voice to this very important conversation, not only as a NICU mom, but also as an advocate for community and a person who leads a NICU support organization. As you heard, I'm Kimberly Novad. I am a native New Orleanian. That is probably my claim to fame. I am local New Orleans, as they say, from here. And we just, put on a great Super Bowl. And so we're excited for our city. But beyond that, I am an advocate. I am a former high school teacher. And most importantly, I am the mother of 2 children, one that you see here. This path to motherhood would change the trajectory of my life. Honestly, 9 years ago, it's 10 years now, I'm sorry. My son Saul was born at 28 weeks and 6 days. And like so many babies in our community of Louisiana, he died as a result of complications of prematurity. A couple years after his death, I founded a local nonprofit organization in his memory. And this was to address the social emotional needs of NICU families. As I had a lot of time and space, I had the privilege of time and space to be able to process my journey and learn what were the things that I needed, what would have been helpful, would have been even better if, but also my conversations and interactions with other NICU families who shared the hospital waiting room with me and walked the floors, the hollowed floors of the NICU. So our goal at Saul's Light is to not only support families, but we empower them in their journeys, and we advocate for policies and legislations that center the unique needs of these families. And so we, in our day-to-day work, support families in direct services. So this is just to give you a little bit more information about Saul's Light and what we're trying to do. We support families with therapy, with peer and group support to counteract isolation and stress, little libraries that promote cognitive development and bonding as a way to heal, as well as social services referrals to agencies like WIC and Healthy Start, or diaper and food banks, anything that families might need as they navigate this journey. Lastly, we provide cash assistance, which counteract basically the barriers that prevent parents from being present and involved in their baby's care. We address social determinants of health, so things like transportation or housing or food insecurity, because these type of hardships are really the barriers that prevent parents from being the type of parents that they want to be. Our work, as you can see here, is rooted in our core beliefs. And so these are the things that guide the work that we do every single day. And we believe, as well as our community partners and the people that we're in relationship with that are healthcare professionals, we believe that every NICU family deserves to be present and involved in their baby's care. We believe that healthcare professionals are committed to saving lives. Full stop. We know that every day you get up and go to work, and it is to make the best decisions, to do the things that are right and best for families. We believe that and we trust that. We also acknowledge that disparities persist due to things like implicit bias and things outside of our control, like systemic racism. We also believe that partnerships amongst hospitals and communities and the individuals within those communities are the first step to making lasting, equitable change. So everything that we do at Saul's Light is with community members, with NICU families themselves, community leaders, legislators, but also with healthcare professionals. Our work is to support them in supporting families. And we all have the same goals, which is something that I'm sure we're going to be talking about all day today. Lastly, this is something I'm going to talk a little bit more about, but just want to give you a snippet of our work. It's rooted in the 3 E's of compassionate family-centered care. And so what these are empathy, empowerment, and encouragement. And so we believe that family-centered care coupled with compassion is the best way to counteract trauma in the NICU. So the 3 E's: empathy, empowerment, and encouragement. Now, I want to move into our work and some of the lessons that we learned from working with families. So I'm a person that has lived experience. I've gone through the NICU. I've had preterm birth and experienced the loss of my son, and now have a daughter. She's 7, and that allows me to compare both journeys, both birth journeys, and think about really what support looks like. Now, with this experience, but also leading a community-facing organization, we're uniquely positioned to understand firsthand the struggles of NICU families that are impacted by trauma. And some of it occurs in their day-to-day lives before they ever even see you. But some of it also occurs within the healthcare system. And so these struggles may start with bias and stigma during prenatal care and continue through and are even exacerbated during the stress of a NICU stay. Families that we work with report feelings of anxiety and fear about the future, about their babies' lives, about their lives. They report feeling a sense of responsibility for being in this situation. I know I can say personally, I felt very strongly for a long time, for years, that it was my own fault that my son was born prematurely and ended up in the NICU. And now all of this machines and doctors and nurses were doing something for him that I or my body couldn't do. And that is a very, very tough situation to be in for parents who are who have given birth. NICU families also express feelings of isolation and sometimes judgment from the very people who are charged with taking care of their babies. And so a lot of times when I talk about judgment and or hostility, no one believes that this is a thing that is happening in their hospital. But I can assure you, speaking with families every day, it's not really about one's intentions, but rather the impact. And as everybody says, perception is reality. When people feel judged, they perceive that they're being judged, then that is, in fact, their reality. And so I'm going to talk a little bit about empathy and how that plays into it. So yes, it is possible that as a care provider, you are treating all babies the same. What I want you to think about today is, what about the families? Are we treating all families the same? Is the care that we're providing for every baby, every family, every time? So This is a challenging notion to hear, but what I want us to be able to do is to learn from it and recognize that the only thing this means is that there is room for improvement. We can always be better, as people, as community members, as clinicians, as, friends. In all of our relationships, we can always be better. And so feedback is really the position from which change occurs. There are few lessons to be learned from the experiences of patient families, and when we hear from them about how they experience the NICU or about these feelings that occur, the lessons are varied. And what I think the most important things there is for us to take away is that there is a great need for system-wide education. And so that begins with exactly what we're doing here today. And so congratulations, you've made the first step, and I'm really glad that you're here. What we can learn from this feedback and set out to do in the future is to learn, one, how to deliver trauma-informed care, which is what we're doing, and this is the first step. Congratulations. But I don't want us to discount the importance of these other things, because a journey of 1,000 steps begin with one, right? And so showing up and being here and taking a part in this conference is one, but there are others. And the biggest ones that I think about when I think about family engagement and patient care are these. And that is learning the history of medicine in the United States, learning about where people's fears come from. So if a family is fearing interaction with social work, the social work department or nurses or doctors, there is usually a reason why they experience that fear. And a lot of times it's not just due to an individual's experience, but sometimes a group's experience. And so learning the history of medicine in the United States is one way to understand why communities feel the way that they do. The next is, it's important to address stigma and bias, particularly unconscious bias. We all have it. It is impossible for any person not to have a bias. This usually just means that, we may have a preference, or we may understand things that we can relate to, or people that we can relate to. We may have ideas about things or people that we don't know. But it's very important to be conscious that it exists, and it's the only way to be able to change it. You have to first acknowledge that it exists, and then talk about and discuss and do things that can change it. The next is familiarize yourself with cultural mores of groups that are not yours. So communities that you are not a part of. Understand how communities react to stress, how people react to grief, how people react to conversations with doctors or people perceived to be in a position of authority. And then lastly, understanding addiction. I feel like for a long time, this wasn't much of a thing that people were discussing, but it's definitely a thing that is coming up more and more as we see people experiencing addiction and recognizing that, it is in fact a public health issue, and we as a community have to rise up to meet that issue. So now is a good time to mention that, change is, it's a journey. not a destination. So there isn't a point in time where you're ever going to be done with any of these things that you see here. You don't arrive, you don't say, I'm done. I did that. I went to the conference, I had the lesson, and now I'm good. On the contrary, being able to apply trauma-informed care or through the trauma-informed lens, and to be able to dedicate yourself to health equity is a work that you'll be doing forever. It is a thing that doesn't end, right? It's like with any relationship that is worth having, you're always working at it. You're always communicating better. You're always giving 100 and hope that the person that you're in relationship with is giving 100 as well. It's the same thing when it comes to healthcare. It's the same thing when it comes to engagement with others. Get back to the 3 E's that I mentioned in the previous slide. So remember, there's a lot of long-term things that you are signing up for when you decide to become a trauma-informed caregiver. But in the short term, there are some very immediate things that this means and that you can do. So things on a daily basis that can change your practice. And so it's time to talk about the 3 E's of compassionate, family-centered, trauma-informed care. And the goal is to counteract trauma by building healthy relationships with patient families in which they feel safe, strong, and resilient during the NICU stay, but also after. The first E is to empathize. So when working with families, particularly from historically marginalized groups, it's important not to just practice empathy, but radical empathy. So radical empathy is defined as actively striving to better understand and share the feelings of others to change our perspectives from judgmental to acceptance in an attempt to more authentically connect with ourselves, which is awareness, the awareness piece, and to be able to connect with others, which is the humility piece. So self-awareness and cultural humility, these are the offshoots of empathizing. The next E is to empower families, and we empower them with shared decision-making. We empower them in their roles as parents and recognizing that it's a symbiotic relationship, that their baby needs them and they need their babies. Not only that, it's important to remember that no one wants what's best for the baby more than their parents. And so they are trusting you to guide them in medical decisions, but they also want to have a say, and they also want to feel that they're being heard. Parents are an integral part of the care team, and so their questions should be welcome, and they should be included at all times. And if it's possible, if parents can be included in rounds, I think that would make a huge difference. The third E is encouraging parents to perform and or do any care task that they can do. So things like taking a temperature, changing a diaper, sponge bath, feeding, reading, anything that allows a parent to create a sense of intimacy and bonding will help the parent to feel more that they're connected to their baby and that they have something powerful and important to give and to offer their baby. Being in the NICU, you feel a lot of times that things are out of your control, that there isn't anything that you can do for your baby, that you have to rely on other people for everything. And this is a thing that grieves quite a lot of NICU parents. And it's a thing that certainly grieved me as a NICU parent. So I like to call this as parents as prescriptions, right? We're going to write prescriptions for a baby, and the prescription is that their parent is there and is doing these things. So I can tell you still to this day, one of my best memories, I'll give you two of my best memories of when my son was in the NICU. The first was being able to read to him. It allowed me to channel a lot of nervous and anxious energy into a book. So it allowed me to be mindful and to share a book as any parent would share with a child. And so for the length of a book, for 5 minutes or 10 minutes, I got to be normal. And that was a really wonderful way to spend time with my child without thinking about what's going to happen tomorrow or what the next procedure is going to be. The second thing is when there was a nurse that was going to change my son's diaper. And so, I was there and I happened to see her and she said, do you want to change his diaper? And as a NICU parent, right, I didn't even know that was allowed. We tend to feel that we have to ask permission for anything. And so this nurse, said I could change my son's diaper. She showed me how to do that in a safe way. And like most parents of little boys, I got a quite wet surprise when my son did what all baby boys do to their parents, right? And it's sort of a weird thing to say, but I can tell you 10 years later, 10 years after his death, I still really look back on that time of light and laughter to be able to say, yeah, I experienced that. That happened to me. My son did go to the bathroom on me. And so it's just one more memory in my, memory box or in my heart that I get to keep of the time that I spent with him in the NICU. Now, I've given you a couple examples from my life. I want to share some examples with you from families that we've worked with. Two examples. One is a mother who experienced substance use disorder. And when this mother went to see and parent her baby in the NICU, I don't like the word visit much because parents aren't visitors, they're parents. And her baby was exhibiting signs of distress as a result of this, the mother's journey with substance use. The mother relayed to us that a nurse that was charged with caring for her baby walked up behind her and said to her, "Look what you did to your baby." And that memory stood out to the mom because she didn't go back to the hospital for weeks. She felt responsible for her child's journey in the NICU, for the challenges that they were facing. And she felt not respected. She felt disrespected. She didn't feel that there was anything positive that she could add to her baby's life at that time. And so really what this mom needed was encouragement, because we all have life challenges, but people don't have to keep reminding us of them. So that's why I think it's really, really important that people begin to understand addiction and what it is and how it impacts people. Addiction, as you all know, is a behavioral neurocognitive disorder. The mother is not to blame for the baby's condition. Rather, the drug is to blame for the baby's condition. And so it took a lot of time for this mom and to be able to feel that she could go back to the hospital without having eyes on her and without feeling the pressure, but to rather to be welcome and to feel that she could still do skin to skin and she still could support her baby's journey to get through the NICU. The next example is a really quick example, but this was a NICU mom who was breastfeeding. And incidentally, this mother was a Black woman. And this is important to the story because this mom found out that another mom, white mom, was offered a food tray from the cafeteria because she was a breastfeeding mom. And turns out this is a service that the hospital offers. What we found from this mom and a few other moms, many other moms after that, is that a lot of the Black moms hadn't been offered the information that food trays were available for parents that were breastfeeding or pumping. And so what we see through research and through lived experience of parents is that quite a lot of people in caregiving positions assume that Black moms won't want to breastfeed. And so because the judgment comes forward in a person's mind, then it influences their actions. So the thought, right, the judgment is the thought, and it becomes the impact or the action that prevents a person from receiving access to the information and resources that they should have access to, because it's important for every family to have access to. So I'm sharing these stories with you today. One, not to ask you to be superhuman and say, banish bad thoughts from your mind. Don't let them get in your mind in the first place. Thoughts are instinctual, and I understand that. But what I want to ask all of you is to be mindful how thoughts influence the care that you give and the actions that you take. So I am challenging everyone here to be self-aware, to interrogate thoughts, and engage in internal and external dialogue, always asking the question, why? Over and over and over, and follow it to get to the roots of the thoughts, feelings, and beliefs. I believe that if we want to deliver trauma-informed care, we have to go inward, and this is absolutely necessary for implementing this approach and advancing health equity. It requires a cultural shift, cultural change, not just at the individual level, but at the institutional level. So what we need from everyone is all hands on deck. If you can empathize with families and see their journeys, how all their experiences and interactions come together to shape how they perceive any given moment in the NICU, then you will be able to empower them in their role as parents. And you will be able to encourage them that they have something very important to give to their baby and that they are the only person who can give it to them. Now, that was super meta, but let's talk about, let's go from theory to practice and what this looks like in action. This is one of my favorite photos. These are real photos, by the way. These are not stock photos. These are the families that we serve, and these are the hospital partners that we work with. So if we are prescribing parents as medicine for their babies, and if we're implementing the 3 E's of compassionate, family-centered, trauma-informed care, what does it look like in action? It looks much like this picture and the words that you see here on this screen. It looks like whenever possible, every baby every family, every time benefits from open communication that is respectful and kind, where questions are encouraged, and that we inquire about a family's life and experience, get to know them, encourage them to do skin to skin early and often, ask about their goals for providing human milk. Try to keep consistent schedules as much as possible and alert families in advance if anything is going to change. And I recognize that that might not always be possible, but to the extent that we can solve for this, it really helps to counteract mental distress and emotional distress for parents. So preparing families for upcoming surgeries whenever possible, answering their questions, and not seeing the questions as being non-compliant, understanding where families are coming from, understanding what they value and what's important to them. Finally, families need to experience that they have a personal cheering squad. Offer words of affirmation, of praise, and tell them how much they're helping their baby. Look at this mother in this picture. Just before this, she was reading a book to her baby, and her baby was responding. And so you can see here that the nurses are all a part of it, right? They're encouraging mom. They're telling her what a wonderful mom she is. They're telling her how beautiful her baby looks in her bow and her dress. And it helps the mom and it helps parents to feel confident in parenting this tiny, fragile human. And if it's possible, I don't know what the phone policies are in your unit, but when you see a really cute moment or something like this, take a picture and share it with the family. These could be the pictures that they will use to tell their story, to share their journey. Or in the case of a family like mine, these pictures will become their memories, the thing that is going to help them heal into the future. So lastly, I want to make a very important part of the journey that we mustn't forget, right? We're in charge of patient care as clinicians. The community and families are in charge as families transition home. But there is a role that we can all play together. And so this is through partnership. And it's to make sure that families feel confident in caring for their babies. Part of this is that parents, whenever possible, should be screened for perinatal mood disorders, and they should be screened for trauma, and they should have a coordinated long-term care plan that's created with physicians, social workers, and community-based organizations. So what is a family going to do when they get home? Are they going to the follow-up clinic? Do they have a way to get to the follow-up clinic? Do they have the information and avenues of communication to be able to schedule those appointments and make those appointments? Are babies being discharged during RSV season? Do families know CPR? Do they have safe sleep environments? These are all a part of the long-term healthcare plan so that we can try to reduce readmissions to the NICU. Accessibility is a huge part. Getting to know families and hearing honestly their stories about what they have access to and what it is that we can help them gain access to. So this is, of course, things like transportation, but what we're seeing a lot in our community lately is language. So are the materials, are helplines, or the people that you call for support, do they speak the same language? Can they support families in their breastfeeding goals in a language that they understand? Can they share books in a language that they understand? So accessibility means quite a lot of things. And this is something that absolutely must be discussed with families before they leave a NICU. So we all know that a family's success after discharge looms largely on how they're supported in the hospital and whether or not they know which resources exist, where they are, what's available to them, and how to access those resources. WIC is a huge one that I've talked a lot about, not just within our community, but within other states across the nation, California, for example. A lot of people that are eligible for WIC don't always get WIC services. So this is an easy thing to discuss with families and to make sure that they are aware that this program is out there, and WIC does a lot. It doesn't just give people breast pumps, but they have a lot of classes, they have support groups, they have material resources, and someone can walk them through the process of applying for it. Early interventions. So I just saw an article about, I think it was from the 19th News, about why so many preterm babies don't have access to early intervention. And so it has a lot to do with bureaucracy. It has a lot to do with different entities thinking that someone else is responsible for it. But it's very, very important that families know, particularly with preterm babies, the earlier you start the intervention, the better. And that is how we catch babies up. So lastly, any sort of resources that are out in the community that a family might need, mental health counselors, resources, diaper banks. All of these things are so important and are not just on the responsibility of the hospital. It's also on the responsibility of a community group. So I would like to encourage all of you to find the community group that is in your area that is supporting NICU families, and figure out if there is a way to sort of spread out this responsibility. You guys are doing the heavy lifting. You're saving our babies' lives every day. But community groups like mine, like Saul's Light, and other community groups that you can find through the NICU Parent Network or the Family Centered Care Task Force. It is our day-to-day work to be able to support families in doing some of the things that you see here. And like I said, support you in your work to support families. It's precisely why I talk about partnership and why Saul's Light is aligned with all of the hospitals here in New Orleans. We recognize that partnerships is the way forward if we want to advance health equity and mitigate harm. It's the way that we reduce disparities, and it's the way that we support families. So what is the takeaway? The biggest thing that I want you to remember is that trauma-informed care and health equity is not only effective, it's compassionate, and it's evidence-based. It protects babies, it protects families, and it protects healthcare professionals. It improves safety and the quality of care. And most important for families, it sets them up for success after their NICU journey. They've already had a rough start in life. What we can do by working together, hospitals, community organizations, families, legislators, employers, is to make sure that we give families the next best step in life. Thank you all for listening to my brother. My contact information is here. Please connect with me. I would love to hear from you and learn about how you're advancing health equity in your NICU and in the community.
Thank you so very much, Kimberly. It's always wonderful to hear you speak. This time around, I learned more about your community journey. The first time I heard you speak, I learned about your family's journey. I took away valuable lessons in how I counseled families. And I mean, I'm just thinking forward to the jewels that you have given us, the pearls, to be able to, you know, further the care that we provide in our units. So as I get ready to introduce our next speaker, I wanted to share with you our disclosure slides. I think you can see it in the chat, not in the chat, but as a shared screen. This is a list of all of our speakers and our moderators, again, confirming that we have no relevant financial relationships or otherwise or conflicts to disclose. And with that, I'd like to move towards introducing our next speaker, who is someone I met and learned his journey through my work at Hackensack. So our next speaker is a colleague at work. Daryl Hughes is a diversity, equity, and inclusion partner for the Hackensack Meridian Health, a multiple hospital healthcare network spanning northern, central, and coastal New Jersey. Daryl reports to the network director of DEI, supporting the leadership of the network's senior vice president of DEI, our chief diversity officer. He serves as a network liaison to 4 of our network hospitals, supporting the provision of equitable healthcare to all communities and patients, and a diverse and inclusive workplace for more than 35,000 team members. He supported HMH's becoming the first health system in the country to receive an advanced certification from the Joint Commission for their relatively newly issued healthcare equity certification, and we received that honor in 2024. He served on numerous boards and committees for numerous community organizations, including the Health Improvement Coalition of Monmouth County, Community YMCA of Monmouth County, Lunch Break in Red Bank, New Jersey, and the Red Bank Charter School. But although these are very impressive accomplishments of Mr. Hughes, he's really here today as a husband and father of twin daughters. And with that, I'd like to welcome Daryl to share with you his journey.
Thank you, Dr. Island. I appreciate the opportunity, and thank you for inviting me to be part of this important conference. Give me a second to share my screen. I'll get started with our story. Give me a second. Okay, can everyone hear and see my screen?
Yes.
Okay, good. All right. So Before I get started, I would like to also acknowledge my fellow presenters who preceded me, Mary and Kimberly. This presentation so resonated with me, and I empathize with um, all that they shared. As Dr. Island shared, I do work in healthcare administration, but today I am here just as a dad with an incredible story. I hope what I will share with you will give you insights that can help all providers and families who walk in the space of what I consider sacred ground, the NICU. Today, my talk will cover the following areas. I will share a learning objective for today. I'll give you an introduction to where and who we were before everything happened. And we'll talk about the day the day my little ones arrived. And we'll then talk about some of the most significant traumas I experienced with my wife during our NICU journey. And most importantly, what we and how we coped, with a hope that it will generate ideas that could be taken and shared with other NICU parents and providers. My objective today is simply to share an inspiring story where hope and faith prevailed in the face of daunting life-threatening odds, and how intentional positivity is necessary for NICU patients, parents, and providers to survive and thrive. So let me start with you by giving you a report. My wife and I learned very early on after our twins were born, on how to give a quick summary of each one when meeting medical professionals. Lonnie, who is now 7 years old, was born at 23 weeks and 2 days, weighing in at 1 pound 6 ounces. She was in the NICU for 108 days and spent 40 days in pediatric rehab before coming home. Lonnie came home on oxygen and had a history of the following due to her extreme prematurity: osteopenia, retinopathy, bottle feeding issues, apnea, and bradycardia. She required oxygen assistance when she was discharged and to come home. And most seriously, she was born with patent ductus arteriosus, which was ligated before she was discharged from the NICU. And for those who may not be familiar with those clinical terms, she had a hole in her heart when she was born, and it was successfully closed through surgery before she was discharged. And I'll talk a little bit more about that as we go. Lonnie's identical twin sister, Jennifer, or baby B, was born at 1 pound 4 ounces. Jenny experienced much more serious complications than her sister. She has hemiplegic cerebral palsy, affecting her ability to walk, talk, and ambulate. Jenny developed life-threatening necrotizing enterocolitis within her first 2 weeks of life, requiring emergency surgery and an ileostomy after 30 centimeters of where 13 centimeters of dead intestines were removed. Jenny then developed hydrocephalus in her 2nd month after her birth. She was so small that a shunt could not be placed in at the time, so an Amaya reservoir was placed in her head to drain fluid by needle inserted into the reservoir. The hydrocephalus appeared after she was discovered to have experienced a stage 4 brain bleed on the right side of her head. Like her sister, Jenny was also born with a PDA, or with a hole in her heart, also requiring surgery. Before she was discharged from the NICU after 188 days, Jenny had additional surgeries to reverse the bowel ileostomy and reconnect her intestines. She also had a VP shunt placed when she experienced hydrocephalus again a few weeks before she was supposed to be discharged. So let me tell you a little bit about us before My wife and I met in 2014 when we were both in our late 40s. We married in 2015 when I was 49 and she was 48. We became pregnant the last week of December in 2016 through IVF after our first transfer. For safety reasons, we agreed with our fertility specialist that we should only have one embryo transferred. Monique knew she was pregnant a few days after the transfer. When she returned for follow-up, her pregnancy hormones were exceedingly high. She was told that she was really, really pregnant. We were ecstatic. This picture is from the night we found out we were having identical twins. Having reached our 9th week of expecting, Monique was transitioning from our fertility specialist to our OBGYN for the remainder of the pregnancy. Our OB conducted a routine ultrasound and told Monique, you know there are 2 heartbeats, right? Monique exclaimed, no, doctor, that's not possible. We had only one embryo transferred. You're joking. Our doctor said, no, I don't joke about these things. There are 2 heartbeats. Our doctor gave her the 2 images of their heartbeats for proof. Monique was stunned, shocked, and a little giddy. On her way home after the appointment, my wife, who has a very good sense of humor, bought these 2 identical outfits and placed them in a gift bag. That evening, I was home getting dinner ready when she shared the news with me. Here's a little clip of what that looked like.
Don't look at the...
No. You're kidding me. No.
We have 2 babies, honey.
What? Are you talking twins?
We're having twins.
No, that can't be true.
We're having twins.
So I do want to point out that if you were able to hear it during the clip, it was just a coincidence that the Climb Every Mountain from The Sound of Music was playing in the background when Monique caught this moment on video. This was not edited into the video for dramatic effect. So this is how our journey started. So let's jump forward to the day the girls arrived. I start with this sentence because this is the thought that flashed through my head, which I think was a critical moment in the next 24 hours that were to come. So what does this picture mean to me? This represents the start of my trauma experience on May 16th, 2017. It's probably around 7 p.m.-ish. I was on my way home from work, and back then I had about an hour-long commute each way to and from work. I stopped at the Lowe's in our town to order new carpeting for the room we were redecorating to be a nursery. I was standing with the Lowe's carpet section associate as he started printing out paperwork, and I pull out my wallet to hand my credit card over to the associate when my cell phone went off. I answered the phone, seeing that it was Monique. I thought she probably wanted me to pick up something from the grocery store on my way home. Hey, babe, what's up? My water broke. I think I said to her, I'll be right there. I told the associate I've got to go home right now. My wife's water just broke. I'm in shock, and I run out of the store to the car. We lived about 10 minutes away from the store, so I got home so fast that I beat the paramedics and the police, who arrived about 30 seconds after I did. I walked into our townhouse yelling for Monique, "Where are you, honey?" For a split second, I think no one is there. Then I hear sobbing and look around the corner and down to the floor. Monique is laying on her side on the floor in the powder room off our kitchen. I think she was still on the phone with 911 and just close to hysterical. Then the paramedics come in and immediately attend to her. Then our police department arrived and began collecting basic information from me: name, my wife's name, age, do you live here, blah, blah, blah. Maybe about a minute's worth of conversation. In that time, the paramedics have Monique on a stretcher and are booking it out the door to get her into the ambulance. They ask me where to take her, and we tell her to go to the hospital we were supposed to have been transferred to for her perinatal care. Once loaded, they tell me I can't ride with them, so I'll have to follow them. Some of our neighbors in our cul-de-sac who came outside due to all the commotion told me they'll close up the house for me and just get going. So I jumped back in my car and follow the ambulance. We live in a rural section of New Jersey, so I'm trying to keep up with the ambulance, who's moving with great speed, but I lose them at a light. The funny thing is, I don't know my way to the hospital. I only lived in this part of this New Jersey for less than 2 years since after moving here when I got married. I had to pull over to pull up Google Maps on my phone to find my way. I'm absolutely panicked, but I'm keeping it together. Once back on my way to the hospital, I just kept saying over and over, God, save my babies, the entire way. It really is amazing how a life or death situation will make you call on God. At the hospital, I arrive at the emergency entrance and have no idea where they've taken Monique. I double park in the ED drop-off area and hastily give my keys to the security guard, asking where and how do I get to the ED. They direct me inside. I get to the front desk, breathlessly telling the greeter that my wife has just been brought in. I still have no idea where she is. Little did I know is that they didn't stop at the ED for triage. They went straight up to L&D. I make it up to that floor and then get told that I need to speak to the registrar to give some info so they can admit her. Name, consent, sign here, HIPAA, billing, driver's license, insurance. It just, once done, I get to her and I expect her to still be with the paramedics, but in that time, Monique had been brought to a labor delivery room, and an entire clinical team was working on her. I walked into the room bewildered and confused. I then was told that she is dilated and that they need to stop her contractions. They give her IV magnesium sulfate and then give her an injection to help the baby's lungs develop. We then settle into a waiting game to see if the contractions will stop. It is now probably about 9 p.m. and just 2 hours ago, I was at Lowe's. Welcome to Monday, day one. Once the magnesium sulfate was hung and the Surfactant injection was done, things just kind of settled down for a while. I'm still in my work clothes, so I find a place to lay down. I think I was actually laying on the vents on the heating unit in the room we were in. My mother-in-law arrived, and this is as reassuring to Monique and I. I dozed for a while, just hearing Monique's OB's words in my head over and over again. Monique had just seen him on the Friday, it's Tuesday, after midnight, where he had told her that I need you to get to 26 weeks. We were at 23 weeks and 2 days. At 1 a.m., one of the medical residents wakes me up and saying that we have to deliver right now because the contractions aren't stopping. I blink to sleep away and swallow. What do you mean we have to deliver right now? They tell me this is the best way to give the babies the best chance to survive. I'm thinking in my head, how can they survive? They won't be viable. We're not at 26 weeks. There is now an entire team of people working on me, getting her ready to take her up to the operating room. They tell me to follow them upstairs. I get to a set of doors and they tell me to wait here as they whisk Monique in through the doors and beyond. Someone asked me, do I want to be in the operating room during delivery? And I numbly said, of course. They hand me some scrubs to put on and tell me to wait here just outside the doors to the surgery room area. I sit down on a stool and wait. I am completely alone. And I want to emphasize that. No one was with me during this period. My thoughts were, I'm going to be a dad tonight, right now. How can this be? After seemed like an hour, it probably was only 15 minutes, someone comes collect me to go into the operating room. I see Monique and immediately sit next to her and grab her hand. She's sedated, but she can talk to me. This is nothing like what I thought this day would be like for us. At 3 a.m., the babies were delivered. Somehow I had never heard this happening before with twins, but ours were delivered at exactly the same time. So their birth certificates have the same time for delivery. I remembered when we last saw their ultrasounds, they were laying head to head on top of one another. So I guess when they were delivered, they lifted them both out together at the same time. I'm told, you have two girls. I am shocked because I can't believe that they are even alive. The pictures you're seeing here are the first moment I met my twins. There were two separate neonatal teams working on the girls, and they tell me that we're headed up to the NICU, and I'm still in shock. They tell me that Monique's going to go to recovery so I can follow the teams up to the NICU. Once upstairs, it's surreal. They first teach me how to scrub in and gown up. And I think, wow, this is like something on TV. As I walk in, this is where it really got surreal for me. Everyone, as I'm walking in, greets me saying, congratulations, Dad. And I'm thinking, why are they congratulating me? They escort me to baby B, which is Jenny, who is on the nearest side of the entrance to this very large NICU. And they begin explaining to me everything that's going on with her. She's on a ventilator and obviously on telemetry. I look up at the telemetry monitor and try to make sense of what it's displaying. I figured out the heart rate, but the other numbers it took me a while to learn what they were. Then they take me over to baby A, Lonnie, who is on the far side of the NICU because these were the only open bays that evening, so they couldn't be placed next to one another. Again, I am entirely alone during this whole time with no family or wife to lean on. I share all this because these moments matter and they are a part of my entire trauma journey. And this was only day one. I stayed in the NICU, shuttling back and forth from one side to the other for a while, and then later I was escorted back to recovery. Monique was just starting to wake up, and my dad, fortunately, was there. I explained to them what the girl's status is, and once Monique is stable, they transfer her up to the maternity unit to a private room. I fall asleep exhausted, still in my work clothes from last night. When Dr. Island first invited me to share my story, this list was the first thing that came pouring out of my mind as I tried to catalog moments of trauma that stood out to me that first day. As I was reviewing this list last night, I realized I left off one additional item from the list, and it was this. Walking down the maternity unit hall later to rejoin my wife after a C-section. And as I was walking, I was hearing newborns crying in the rooms along the way with their mothers. It broke my heart because when I got to her room, there was just silence. The morning after the girls were delivered, we had our first visitor. It was the renowned perinatologist to whom we were in the process of being transferred to when the girls arrived early. I'm going to read from a letter my wife sent to the hospital months after we brought the girls home. My husband Daryl and I had the opportunity to meet you on May 16th, 2017, hours after I had given birth to our daughters, Jennifer and Lonnie Hughes, at 3 a.m. Daughters were born at 23 weeks and 2 days. I will never forget the conversation we had with you, which occurred about 6 hours after I'd given birth. You entered my room and introduced yourself, and at first we were excited to meet you because my gynecologist was in the process of referring me to you. He'd spoken very highly of you, the perinatal medicine department and NICU departments at this hospital. Our excitement to meet you soon dissipated after you began talking to us. My husband and I were still in shock over the fact that I just had an emergency C-section and delivered our daughters so early, and that they were in the NICU fighting for their lives. You didn't take time to congratulate us on the birth of our girls, but proceeded to arrogantly ask us why we didn't come to see you sooner, and that their prognosis didn't look good, and that the next 72 hours were going to be critical. You did indicate that we had one thing going for us in our favor, and is that our daughters were Black, and that statistics show that Black girls have the highest survival rate compared to Black boys, white girls, and white boys in the NICU. We are happy and grateful to God, the NICU doctors and nurses and staff who provided exemplary medical care, and for the thousands of prayers that have blessed us with our now, at this time, 1-year-old daughters, who are now doing extremely well given the grave condition in which they arrived. While you may not have been aware of this, we were deeply upset and shocked by how you spoke to us during such a traumatic moment in our lives. We felt that it was disrespectful and insensitive, and not what we would have expected in the bedside manner of such a preeminent physician. We hope that no other couple will have to ever experience what we did with you on that day. Please be more sensitive to the emotional state of couples who are going through such an experience. Your words matter, and they can have the power to encourage a family during a difficult time, or they can remove all hope. One positive thing that did come from that discussion, your words did help resolve my husband and I to dig deep and fight for our girls. After the despair we were left in after your discussion with us, we refused to accept that our girls could become one of the statistics you quoted us. We advocated and fought hard for our girls each day, and with God's help and grace and strength, until they came home to us. Remember, when you are talking to parents, statistics mean nothing. You're talking about real children and real lives. While we were angry, we know that the work that you do is important and saves lives. Please continue in this important work, but take a moment with each family facing challenges like ours to encourage and lift their spirits. Kindness, gentleness, and a softer approach can go a long way in helping parents like us get through such a difficult time so they can be the true support that their babies need. Thank you. This letter captures the essence of probably what our deepest moment of despair, but it also captures the resilience and resolve we had to find within ourselves to endure and not give up. This letter led to a meeting with the hospital president, the CMO, the CNO, and the patient experience leader at that hospital. There were so many difficult moments that we experienced during our NICU journey with our girls, but I probably would need a few hours to recount them all. However, I'd like to tell you a few that stood out to me. The first one was getting a call that Jenny had a stage 4 brain bleed, and just begging God for a sign. It was a Saturday. I was home by myself. I think Monique was probably running errands, and my phone rang, and I saw it was the NICU. I don't remember who it was who called me, but I remember the night before they had brought a portable X-ray machine in to take pictures of both of our girls' heads. I figured this must be the doctor calling me to let me what the results were. When they said that Jenny had a stage 4 brain bleed, I got off the phone in complete shock. I was devastated. I just started saying out loud, God, I need a sign. I need a sign right now. This is tough. I kid you not a few minutes later, the phone rang again. I was told that Lonnie's x-rays were negative, other than a very small cyst. She had no brain bleed. That was my sign. Another incident involved a IV mistake, IV pump mistake. One night, I was visiting the NICU and I noticed that the fluid rate on Jenny's IV pump was a little different number than it usually was. And kind of made a mental note of it, but didn't really say anything about it, thinking maybe the doctors had changed something, and I just went home. The next day, my wife arrived in the morning and was greeted by Jenny's daytime nurse, who was one of our primary nurses. This NICU, where we were, allowed us to select our favorite nurses after the first weeks, who were called primary nurses. Each twin had a set of daytime primary nurses and night shift primary nurses. The idea behind this was that having the same nurses allowed them to really know their infant patients and be able to anticipate changes or preferences exhibited by the babies. This also gave continuity and familiarity to the mom and dads when it came to communicating with the clinical team. Our primary nurse for the day shift caught that the fluid rate on the IV pump was off by a decimal point. So instead of something like 70 mLs an hour, and forgive me if I'm not exactly quoting this clinically accurately, but just to give you the relative experience, it was maybe it was like 70 mLs an hour, but she was getting 700 mLs an hour. Once our neonatologist assessed the situation and that there had been no damage to Jenny's kidneys, we were able to calm ourselves. The nurse who had set the pump up the night before was not one of Jenny's regular primary nurses, so she unfortunately missed the error. We immediately requested this nurse never be assigned to either one of our girls. Another instance of trauma was when Lonnie became unstable, literally in front of my eyes, during a visit from my younger brother, who was visiting our girls for the first time. This is really when Lonnie had to really go into immediate heart surgery to address the PDA, a hole that was in her heart because she had become so unstable. It's interesting because Lonnie was always our stable one between the two. She really kind of been uneventful up to this point. But it just so happened that when my younger brother had arrived and came from the airport, we went to the hospital together. And I was a little bit hesitant for having him come out so far because I just didn't know how things were going to turn out. He insisted, and when I protested, he said he had already bought his plane tickets. He is a great uncle. I was so relieved when I saw him and to have his brotherly support. He came straight from the airport and met me at the hospital. I escorted him up to the NICU and taught him how to scrub in so we could enter the unit. Having been there already for a few weeks, going into the NICU for me was a routine thing. For my brother, who had never been in the NICU and had two children with no NICU stay, it was quite an experience walking to a busy NICU with telemetry alarms going off all the time and babies in isolates all around. We stopped at Jenny's isolate first. She was nearest to the door still, and I could tell that Jason, my brother, was stunned by what he saw. Jenny was on a ventilator at the time, and she was recovering from her intestinal surgery. We then moved on to Lonnie's isolate, and Jason immediately reacted to my face when I saw Lonnie's telemetry monitor. Her oxygen saturation numbers were fluctuating, and her heart rate just was not steady. After a few weeks of being in the NICU, I could look at the monitors and know when something was wrong. I called Lonnie's primary nurse over, and she told me that they were concerned about the fact that Lonnie was becoming unstable. I took my brother off the unit, and I immediately broke down crying. This was the start of Lonnie's requiring immediate cardiac surgery to ligate her PDA. She was so unstable that the cardiac surgery team that came in to do the surgery had to do the surgery in the NICU itself, which was shut down to visitors during the surgery. So the entire NICU, everyone All other parents, no one else was allowed in the NICU while Lonnie was undergoing her surgery. I spoke about Jenny's multiple surgeries and complications in the intro, so I won't go over each one of them, but I can tell you that each one was traumatic to experience as a parent. I remember each surgery day, waking up with my wife, getting ourselves ready for the day to come, driving to the hospital knowing that our baby was about to undergo a major surgery and she wasn't even 10 pounds yet. I cannot describe to you what it was like accurately, but each surgery was a test of our faith, perseverance, and resiliency. So I'd like to share with you a few ways that we got through our journey. These are just a few tips that I wrote down a few years ago when I was contacted by a support website for NICU parents about how we got through our experience. And this is what I wrote. Do not allow anybody to quote you survival statistics or risk percentiles about your children. This is done to manage expectations because the NICU journey can be arduous and fraught with steps forward and backwards. They don't help anybody in the midst of the journey. You may have to muster all you can to remind the doctors that your twins are not statistics, or your children are not statistics. They are living, breathing human beings fighting for their lives, and they need all the hope, love, and dedication they can get in order to survive and thrive. Avoid Googling. Trust your doctors. If you don't understand something, ask them to explain everything to you. I made the mistake of trying to read studies and publish medical articles online, and in an effort to understand what was happening, it just exhausted me. I learned to stay in your lane. Studies and papers and such are for the doctors and nurses. My energy was better served by focusing loving affection on my girls and my wife during this time. The NICU nurses are your rock of support. Listen to them in all things they recommend. I can't say enough about our NICU nurses, particularly our primary nurses. They became like family to us and to the girls. Their wisdom and experience kept us connected to all that was important, and they never failed us being there when we needed them. Fourthly, we always presented a positive attitude around our girls and our providers, no matter what challenge we were facing. I truly believe that our girls felt that, and that's what helped bring them home. So a fifth point, fierce love and not accepting defeat and despair were key. We were in a life or death fight and had to conduct ourselves accordingly. Knowing that helped us steel us for whatever came our way each day. I think we also inspired our clinical teams as well to keep up the good fight for our girls. When they saw us coming into the NICU each day with our heads held up high and smiling, I think it gave them hope and inspiration. And most importantly, faith in a higher power, in whatever form you believe, ultimately got our girls home. I'm not here to proselytize or endorse any particular faith or religion. I'm not a churchy guy in the least. But I do believe the NICU is a sacred space and that miracles do happen there. My girls are living proof of that. Normalizing our experience was also a key part of how we made it through this long haul. So we developed a mantra for ourselves that helped us put us in the right frame of mind each day, and it went something like this: "You are perfectly made by God, and you will show and tell us what you need, and you will be coming home to us in God's speed." This mantra or declaration gave us strength and made us stay in tune with whatever each twin was showing us each day and helped us keep our objective always in sight. These routines became our new normal. In essence, we normalized what was not a typical journey for new parents. That included dropping off milk every day on my way to work, on my way home from work, visiting the NICU, daily and twice a day phone updates from our day shift and night shift staff, praying each night for a normal night, at some point we had been in the NICU so much that when I would arrive in the NICU, the staff would greet me like I was Norm from Cheers, as as he would walk into the bar. Um, Again, I think that sense of humor was really a key component that I think helped me get through this. I learned how to read the monitors and knowing when someone was desatting or they're Brady or whatever, what an event was looked like. It really was part of that routine. And then I heard Kimberly in her presentation talking about hands-on, being hands-on. I actually learned how to change the girls when they were, we both actually, my wife and I both learned how to change the girls. So we had hands-on experience. These normalizing routines incorporated the NICU experience into our own daily lives. I think it became part of our own survival mechanism so we could create some semblance of sanity and order during such an uncertain period of our life, um, particularly being as a couple and as a new dad and mom. The next few slides I'm going to share are along the way are just illustrate what this looked like. This is Lonnie on event very early on. Lonnie always grabbed my finger, and even to this day, she continues to grab my hand. So that again, referring to what Kimberly spoke earlier about touch, we learned very early on that when we were able to, and when the girls were able to tolerate us touching them, we did this unfailingly. This is Jenny. And once again, that touch was a daily part of our routine when as the girls were developing. I share this picture in the next slide following this with you because I want you to notice, looking at our faces, we were smiling, we were involved. When I look back at these pictures, I can't now, I sometimes I think about how sick the girls were. I can't believe it. But we were joyous that the girls were here, and we were determined to always present a positive, happy face to the girls each day. This was the first day I ever held one of my daughters. It was my birthday and the best birthday present ever. Lonnie was the first to receive kangaroo care from us. And if you're not familiar with kangaroo care, and again, referring to Kimberly, that chest to chest or touch, where she could lie on my bare chest and hear my heartbeat. I'm eternally grateful to our NICU nurses who organized everything for this moment. In this picture, you'll see Lonnie sleeping, and in the background, you'll see a picture of Monique and I on our wedding day. Our NICU nurses encouraged us to bring in pictures of ourselves to put in the isolette of each twin so they could see us at all times. One of Jenny's primary nurses was deeply spiritual, and that resonated with our own spirituality. So she posted biblical verses in the isolate around the girls with our permission. We were fine with it. I just those verses gave us so much inspiration, encouragement each day. Music has always been a part of my life, and Dr. Island, I know I'm running. Just being mindful of time. If I'm running a little bit long, just let me know. I just have a few more slides to get through. Um, Music has always been an important part of my life, and it was a gift of how that I know I had to share with my girls. So if you take time to listen to the noise level in a NICU like the one we were in, you begin to realize that your babies are constantly bombarded with noise. So I got the idea that putting up a mobile that played music would help give them something to listen to other than telemetry monitor alarms. I found this one at a baby store and hung one in each of our babies' cribs. It also gave them something to look at when they were awake. I was quite proud as a dad for finding these mobiles for my girls. Also, if you can see in the picture, this also was another shot you see on the bars, our picture and another biblical verse of inspiration. In closing, the girls were born on May 16th. Lonnie came home first on October 11th. By the way, a week before Lonnie was due to come home from rehab, I developed appendicitis and had to have an emergency appendectomy. At one point, my wife had me on one floor of the hospital. Jenny still was in the NICU on another floor, and Lonnie was in the pediatric rehab at another hospital not too far from where we were. Jenny came home on December 21st, a few days before Christmas. These pictures are from our first Christmas with our girls from home. At first Christmas home with our girls. Lonnie is on the left and Jenny is on the right. This is a picture of a typical feeding or in those early days. One good thing about our NICU babies is that they came home on a schedule, so they did everything at the same time, which made it much easier for us as for parents with multiples. And this is us just last year. Lonnie's wearing glasses and Jenny's seated on the left. They're second graders now. They do have some developmental challenges, but as you can see, they are happy and thriving. I look at them each day and know that miracles do happen. I know the statistics and know that we could have easily been on the other side of the outcomes we have been blessed with. However, I do believe that never giving up hope and an abiding faith got us to the other side. I thank you for your dedication to all the NICU babies and their parents, and hope that something I shared with you will continue to inspire you in the work that you all do. Thank you.
Thank you so much, Daryl. I feel like Mary. I feel like I need a moment to process. This has been incredible, hearing from each of you, hearing about your different journeys in the NICU, Mary as a provider and then as an educator, Kimberly as a parent, and then as a community educator and advocate, and you, Daryl, as a father, as a work colleague. This has just been enlightening. One of the things that Kimberly said is that we all have biases. One of the most striking things to me that you said was how alone you felt as a father, waiting for the C-section to happen, going into the NICU. I had never thought of how it must feel for a parent to walk into the NICU alone, to not share that joy with their partner, with other family members. And it inspires me to be better as a provider, to be more attuned to what it means to walk alone, to come alone, to experience all that happens in a NICU. So thank you so much to our first three panelists for just, enlightening all of us. To our participants, please take this time to enter your questions in the Q&A session. We like to take advantage of the expertise of our panelists by asking them more about their journeys, to ask them to continue to help enlighten us. And with that, I'm going to ask our panelists to come on camera, and I'm going to turn it over to the other moderators to start to walk us through, some questions and comments from our participants today.
Okay. Thank you. I want to echo what Dr. Island just said. Thank you so much for sharing your stories. They truly impact us as providers and caring for your most precious gifts. So it means the world to me as a nurse that you shared these stories with us. One of the questions, one of the first questions, and it's really more towards you, Kimberly, is from someone who's logged on, is how did you actually, start your organization? How did you connect and really get that off the ground, like working with the NICU? Is it the NICU that your son was in, and how did that actually develop?
Thank you for this question. I want to point out that I think the first steps of starting this organization was that I had the privilege of healing. I had quite the grief journey. I fell down the rabbit hole of grief, if you will. But I was able to be connected to a therapist and made use of all the things, talk therapy, prescription drugs, yoga, mindfulness, meditation, journaling, all the things. But once I had that time to process, for me, there was a shift in my life. I felt that I couldn't go back to my life as I knew it, and I knew that something had to change. And realizing that there were so few resources for families who had experienced the NICU and virtually none for parents who had experienced the death of a child, I knew that something had to change and that it was going to be me. So, that phrase, for such a time as this, it was, I say to this day, it was hard won. And, if I could go back and have my son, I will always choose him. But this is the life that I have right now. And so every day I try to make the best of it. And with that being said, good old-fashioned community organizing. I was well received at the hospitals. Initially, I went to the ones that my son was a patient at. And then from there, it grew based on reputation. And so I'm very thankful for the doctors and nurses who really welcomed me aboard as a part of the team to say, okay, here's a lady who has demonstrated she's interested in changing, birth outcomes and changing things for parents. Let's work with her and see what happens. And so over time, we built a relationship that's based on trust. I trust absolutely everyone in healthcare. I absolutely trust them. And I know that we all want the same thing for babies and families, and that's for them to be healthy and safe. And so that continued dedication is something that we're all working at. I'm working at, the community is working at, doctors, nurses, social workers, we're all working at it together. And I really, really love that. And I think definitely it's the way forward to advance health equity.
Great.
Thank you. The next question from the participants today is for you, Daryl. And as someone who, in every unit that I worked at, I believe in an every parent, every day communication model. So the question from our participant is, what type of information made the daily updates meaningful and helpful? What things did you find were not helpful?
Well, first of all, thank you. It was a great question. Really, the communication was each day was like either she had a good night or a good day, and we were always updated if there were changes to the treatment plan. If we would always get an update in person when we were there because we were there every day, every night. Um, I literally cannot think of a night that we weren't there. But we would always want to know in the morning when we're getting up for the day, getting started as to how did the girls do last night? Because as a parent, you're not there with your parent with your children. And in this, we were in a long haul NICU experience, so we needed those updates to kind of know what to expect, when things were, if the doctors were concerned about something that was developing, that we were informed as early as possible about that. So those sometimes those calls were jarring. They could be traumatic because you would get a call and say, we had to go up on the O2 tonight. We didn't want to, but she needed one of the girls needed more assistance, and that back sort of that two steps forward, a step back, that constant, was, and you could do that could happen in between morning and the afternoon and the evening call. So to answer the question, it was really just the check-in, like how are the girls doing today? Did they sleep well last night? Did they feed well? Did they make urine? Did they, those were the things that we would get every day. Then we'd get a more full picture when we were there on site. It also gave us a heads up if we needed to plan to say, hey, something's happening. I need to call work and say, I got to go to the hospital instead of going to work, because something was going on. So I hope that answered the question.
Thank you very much. And thank you to all of our speakers today for staying online to allow for some questions from our attendees. So the next question I will share, I believe this will direct best to Mary. From our participant, if you're looking to implement an education program on trauma-informed care in the NICU and evaluating the effectiveness of that program, can you recommend any validation tools to assess the effectiveness of the program in the NICU?
I've not used this tool myself, but I know that there's this tool called the Arctic tool. Let me pull it up there. Attitudes related to trauma-informed care. It is a validated tool. It's not specific to the NICU. I've used some other tools, but I don't know if they're validated, so I am happy to circle back. But I think it's one thing to educate people, on the early life adversity and the long-term outcomes and all that kind of stuff. It feels like a whole other kettle of fish, though, to translate that knowledge into, sustainable practice change that's a reflection of that integrated and synthesized knowledge. So, QI initiatives that are collaborative QI initiatives with parents as partners and clinicians and anyone else, that is in that circle of care delivery or healing space, needs to be part of this and figure out what are those metrics that really reflect our goals or our intentions of what trauma-informed care looks like in this setting. Does that make sense? So there may be a fair amount of qualitative data that you might want to look at, but I find, it's good to look at both, right? Get the quantitative. We educated you. How much of this stuck in your head and your heart? Good. Now, how is that, kind of oozing out through your fingertips, kind of a thing, in more measurable, sustainable ways? And, what gets measured gets I'm sorry, what? Help me. We got to measure what matters to us, right? And so really kind of identifying what those metrics are and reporting on them regularly. I mean, I bet Terry and oh my gosh, I apologize, I've forgotten your name now.
That's okay.
You could probably share a lot of like the strategies that you guys used in doing this, but keeping it top of mind is wicked important as you're navigating that. So I hope that was helpful answering that question.
Yes, thank you.
Absolutely. Both Kimberly and Daryl, I think you both touched upon this, but one of the questions we have is, how can we help families as the healthcare team? How can we help families who lack that trust in medical care, in the healthcare system? What is something, as your experience as parents, that we can do to kind of assure them and help them in this trusting relationship?
I had the privilege because I worked within healthcare, so I didn't have a distrust of our medical professionals who supported us. But I do think that it starts with that. It could start with those one-on-one relationships. I remember the the first night, the way that the NICU nurses um, bonded with us and connected with us and um, uh, and I'll say for myself that first night again being alone in the NICU um, and developing what became lasting personal relationships, you know, if you will, friendships or with the nurses. So it took that one or two nurses that just took your hand and just spent a moment trying to reduce the intimidation of what was going all this environment. They were used to working in an environment, but these were a new environment for us. And so, you know, giving that kind of comfort and reassurance, I think, you know, making that connection with one, just one at a time made a difference. Even with the doctors, there were some doctors who were much more arm's length, and then there were some that you felt that they believed in they believed in our girls, and we felt very close to them too. So I don't. Again, I hope that answers the question. It's we probably could talk a whole time for that, but it's a great question.
Agreed, 100%. It's that intentional positivity that you spoke. I think that's the a good takeaway from that.
Mhm.
So thank you.
I would second what Daryl said about building relationships, and it takes time. It's not an automatic thing, you know, you really have to sort of build up to having trust in a provider-patient relationship. And I think just to throw it back to the presentation, thinking about where you are and what context is, right? So here in the South, a really big thing is like speaking to everybody, right? It's a respectful thing to speak. So I think it's important, particularly for clinicians when they come into a room and they see a family, to speak to everyone who's there. And if this person is older than you, then add a Miss or a Mr. in front of it. So just to, you know, really lean into what are the cultural mores of a group, a patient that you're serving, and let the family lead and know that relationships take time, as all good things do.
I just want to add to that. I agree with Kimberly. I mean, we had the experience of actually our neonatologist who was with us for the whole journey. When when we first met him, he walked into the room we were in. He was in scrubs. I couldn't see his badge or anything like that. I thought he was like the you know, EVS staff coming in to you know, he didn't introduce himself. He didn't say, you know, he just started talking. It wasn't until like 5 minutes I realized, oh, this is the doctor for our girls. So I agree with Kimberly. Those mores and just common courtesy things go a long way. And there's some cultures where that is much more neat, or in, you know, regions of the country where, you know, but I think it's true anywhere that identifying yourself, who you are, because you're bombarded with so many different people in those, like in those first 24 hours, you just don't know who you're trying to remember somebody's name. I started writing down, I had a notebook that I started writing down everybody's names. I wanted to be able to thank them later, and I just said, let me capture this now. So I still have that notebook. Thank you.
Wow. Thank you to our panelists. We could, you know, I'm sure if we stay here for an hour, there are a multitude of expressions in the chat of gratitude for all that you've shared today, questions about your experiences. But I want to give our panelists and our participants the opportunity to stretch their legs, take care of their needs before our next speaker joins us at noon. So thank you, everyone. We will have opportunities again towards the end for more questions. So I appreciate all the questions that have been asked. But let's all take a break and we will regather at noon.
Thank you.
Thank you.
Hi, I'm sorry. I see you have your hand raised. Oh, welcome. You're on mute, so I can't hear you.
Sorry, I didn't mean to raise my hand. I was just
Okay, no problem.
I was just
No,
sending a chat and saying like, so I'm here. Do you want me to you want me to share my screen and run the slides myself?
yes, please. So, just before noon, I'll take this down and then
Yeah,
hand it over to you.
okay,
I'll introduce you as well.
great.
Okay, terrific.
Apologize, I couldn't join you earlier. I'm still at the Vaughan meeting.
Not a problem at all. Just great to see you. Welcome back, everyone. We are going to continue with our program. It gives me great pleasure to introduce our next speaker, Dr. Jochen Profit. He's an endowed professor of pediatrics at Stanford University School of Medicine. He serves as co-chair of the California Maternal and Perinatal Quality of Collaborative. Dr. Jochen's primary interest is the optimization of quality and equity of care delivery to sick newborns. This interest includes healthcare delivery design at the macro system level, organizational context at the hospital and neonatal intensive care unit level, as well as improvement of care processes in the clinical setting. In addition, he has a keen interest in the use of information technology to support families, care professionals, and policymakers in their efforts to facilitate optimal care. He has many administrative appointments, including co-chair and co-principal investigator of the California Maternal and Perinatal Quality of Care Collaboratives, Chief Quality Officer of the California Perinatal Quality Care Collaborative, as well as the Chief Scientific Officer for the California Perinatal Quality Care Collaborative. He is the recipient of multiple NIH grants supporting his work in optimization of quality and equity of care for newborns. Please join me in welcoming Dr. Profit. We're thrilled to have you here with us today.
Thank you so much, Lisa. What a pleasure and privilege it is to be here today with you. Let me share my screen, my slides with you. Okay. Can you see this?
Yes, we can.
Okay, great. Wonderful. So good morning, everyone. I'm speaking to you from a very cold hotel room in Minneapolis. It was like just barely 0 degrees here, and hopefully they won't interrupt my Wi-Fi as I asked for a late checkout. But I'm glad to be here with you, and hopefully I can provide you with some new information on how we in California are trying to address health disparities, health equity in the NICU space. There's a couple of disclosures. You can see them here. You can have the slides. So we are the state collaborative. I think you're probably familiar with those from many of the WAN collaboratives. So we are a state collaborative in California. We're sort of the first perinatal collaborative. So we have a maternal side, we have a neonatal side. A maternal side kind of grew out of the neonatal side. And then we also have a high-risk infant follow-up network. There's about 66 clinics in California, and that's a pretty unique kind of setup. So that we're really able to track kind of care and outcomes for babies from the maternal side to the babies and then to follow up, which is a really neat opportunity in a large state. Allows us to do a lot of things, mostly focused on improvement, but also sort of epidemiologically. So we're always trying to make California best place in the world to have a baby. That's our goal. And then kind of here's how we do it. It's sort of five main categories, I'd say, that in which we work. So the first one is kind of everything in quality has to start and end with data. So we do a lot of have a lot of focus on obtaining data, cleaning it, making sure it's good and reliable data, and then feeding it back to hospitals and benchmarking them against each other, because nobody likes to look bad in front of their peers, and so it's a big motivator for improvement. And we conduct collaboratives across the state, which vary in size. They can be small, they can be very large, typically around 25 to 30 or so hospitals engaged, and we come together through a kind of collaborative improvement process similar to Vermont Oxford although like with some sort of differences in terms of how kind of streamlined it is. We do a lot of education and outreach. We do research with the data that accrues, and we have a lot of partnerships. We're really a multi-stakeholder organization, includes the state as a very important partner, of course, and to some degree the federal government with some funding, but then also like community organization, increasingly foundations, etc., other kind of partners in the perinatal health space. This is just us by the numbers. There's again, we're like a pretty large state. There's about 400,000 births, maybe like about every 8th baby or so in the country is born in California. There's about 40,000 NICU admissions every year, and we've now expanded our data set to really have some information on every baby that hits the NICU. There's 135 NICUs currently in our network, which is more than 95% of the hospitals in California, and there's about 220 birth hospitals which enter our systems through the maternal side. We're unique also in having an acute neonatal transport data set, and in which we can track kind of the quality of transport and across hospitals. Then I spoke about the higher skin follow-up, and there's about 9,000 entries of patients into that every year. So a rich kind of system and opportunity for improvement. This is just a snapshot of the kind of like feedback reports we provide. This is sort of like a dashboard that you would enter as you go to our report site, and it gives you a lot of information on different kinds of things like organizational features for your NICU, and then this is actually, I think, like statewide data, because no hospital has 28,000 live births, but at least it's a region. But anyways, it's like rather than going through these individual pieces, there's, you can see that there's small babies, there's big babies, there's additional items that I'm not showing here that you could scroll down to. And then a lot of this work is actually influenced by our members. So our hospital NICU members, they sit on a lot of our committees and volunteer their time. We get over 100 hours of volunteer work a month from them, which we're really blessed to have. And they are really the ones who decide kind of like what it is that they want to see in our reports. And so we try to follow their lead, and it's really kind of a democratic bottom-up organization. Here's an example of an SPC chart. If you're quality improvement, it's the kind of like chart you want to look at over time, and like these are, so people can drill down from the dashboard that I showed you. They could drill on hypothermia, and then they would get like more specific detail. Like we've done improvement collaboratives. The reason I'm showing you all of this is that I want to show you how we're translating what we've done for quality always for equity. So bear with me if you think this is just sort of an advertisement for quality improvement. It will come together at the end. So rather than talking about all of our different improvement efforts, maybe I'll just direct you towards this like antibiotic stewardship effort. Really what happens in our data set is we see variation everywhere, right? And variation is typically sort of pretty large between like the bottom and top performing hospitals. And what we want to see sort of over time or through this improvement collaborative is that variation to get tighter. And I think this graph just sort of illustrates this beautifully, how as we kind of standardize care and teach hospitals the improvement efforts, like care becomes more standardized, variation goes down, and improvement and performance overall goes up. We do a lot of education. We have an annual conference. It's always in March, just before like the couple of days before the Gravens conference. If you go to that one, and like there's hot topics in neonatology, and we of course on the West Coast are the cool topics conference. But the cool topics conference is preceded by an annual CPQCC conference, which we call Improvement Palooza, and there's a lot of kind of focus on a variety of topics, but over the recent years, sort of very heavy focus on family-centered care, which you'll understand why in a second, as well as health equity. We do believe that like we should use this data not just for improvement work, but also for research and publications because there's generalizable knowledge that kind of comes out of these things. But a lot of the work is related to quality improvement, or most of it is. And we try to involve trainees, always not just from Stanford, but from kind of all over the country, actually. So there's opportunity to collaborate. This was just an example. I'm not going to go into much detail, but an example on essentially how we, like, through a forcing function, required every hospital before they submit their data to us to essentially refer patients to high-risk infant follow-up. Because initially we found that one of the reasons why patients don't show up in high-risk infant follow-up is because they were never referred from the hospitals, and that affected predominantly low-income hospitals and communities. And so by kind of like using this forcing function, like now almost every baby in the state is referred. This is another example with Sarah Coons, who was a fellow in Boston, who's working with us on trying to measure kind of care regionalization. We're using mathematical tools to kind of go beyond just sort of the usual saying like this is a level 4, this is a level 3, but actually like measure networks mathematically and then look at their quality and their outcomes. And there's some interesting equity findings in this work as well. So like what's been our impact? We published this a couple of years ago, sort of over like a 10-year time span. And during a time when really not a lot of innovation has happened in the field of neonatology for these preterm babies, right? Like, but we've really shown substantial improvement in things like mortality, right? Like by 15%, multi-morbidity, like more than 3 of these sort of severe morbidity is reduced by over 40%, which I think is quite amazing. Necrotizing enterocolitis, even though we don't exactly know what helps it, maybe outside of breast milk feeding, 45%. IVH down by like 19%. Also don't really know how to improve that. So standardizing care has been helping that. ROP down by 36%, a lot of work around oxygen. And infection rates, which when I was a fellow were just like a given. Every baby, because they're tiny, would have an infection. It's declined by 44%. There's many hospitals in California that don't have any infections, early or late onset, for years. Our maternal side, just to kind of give you an idea too, they're in the news a lot. Maternal mortality, of course, a really high importance topic over the couple of years. It's been going up. And so CMQCC has kind of worked on this sort of very early on, and you can kind of see like over here on the blue line here compared to the rest of the country, California has been actually able to pretty much hold down maternal mortality rate relatively stable over the past 20 years. So a lot of effort happening here. Elliot Main was the medical director, kind of responsible for a lot of these successes. And there's others, but I thought I'll just show you this one. So this is what you're here for is like disparities in perinatal care, and I've sort of given a version of this talk for a while, and maybe now I don't have to quite as much persuade people that there are disparities, but like very frequently when I would give this talk, somebody in the middle or at the end would stand up and be very offended and sort of say, well, this doesn't happen at my NICU. We treat everyone the same. And so before we kind of dig a bit into the data and the way that we've thought about addressing disparities in care, it's like, I think it's worthwhile kind of reminding ourselves that we've been fantastically successful in our field in improving care, right? I mean, if you look back, like what's happened like over the course of a century, it's like maternal mortality, which is currently a national like health policy crisis, is almost like unmeasurable compared to where it used to be like 100 years ago. And in infant mortality, we've also made substantial gains over the past 100 years. But nevertheless, there's continues to be room for improvement, also compared to other countries, and also, of course, in the equity space. And I apologize I wasn't able to join you earlier. Maybe you've seen some of this data already, of course, or know this. Anyhow, that there are substantial health disparities in newborn health, but also in maternal health. And I just thought I'd show you this. This is California data. And then you can kind of see these time blocks here on maternal mortality by race, ethnicity. And these are always like 3 years of data, 2012 to 2014, 15 to 17, 18, and 20. And you can see that across the time, there's sort of, there's about maybe like a 3 to 6 times higher Black maternal mortality, even in a state that sort of, supposedly is doing so well in maternal mortality compared to the rest of the country. There remain these disparities, and so there's still work that needs to be done. Very different similar graphs for infant mortality, which of course often are driven by prematurity rates. All right, so when we talk about health equity, it's always important to know that we all come to this table with our own biases, right? And sort of our initial question was like, well, is this like a little cocoon? Is the NICU a social cocoon where we all kind of can like check our biases at the front door and just go ahead and treat every baby, and every family the same? And so, I like this kind of picture because, I think people might have, like when I can teach a class at the school here at Stanford, like I ask people what they associate with this picture, like actually very different. People will mention like very different things. And so it's just important to recognize that we all kind of have our own biases that we have just kind of growing up in our environment and the things we hear, but that are also kind of baked into the things that we use sort of every day. And so this is kind of a classic example. Google has changed this now, adjusted their algorithms, but a number of years ago, if you would put like 3 Black teenagers into a Google search and 3 white teenagers, you would get these kind of pictures, right? And you can kind of see how like these are all kind of like mugshot looking pictures, almost like threatening. And here's a happy-go-lucky kids, right? So like there's biases in our world that are sort of where we don't necessarily maybe expect them, but we're constantly exposed to these sort of messages. So here's kind of like how we thought about our work. So there's what's called social determinants of health, like the Joint Commission now calls this health-related social needs, trying to follow their lead here, but everybody can understand social determinants of health better. And all the things of like that are involved in this is like parks and transportation and rights and access to food and education and homelessness and income, of course. All of these things will influence like our epigenetics, it's been shown, but also influence just the health of the pregnancy. And the health of the pregnancy then results in the event of prematurity, or at least influences how healthy the baby is at the time of birth. And then, and we all know there's been like decades of literature around social determinants of health and the inequities that exist here. But there was pretty little really literature around like, okay, what's happening like after the babies are born? Are we achieving any reduction in disparity after they're born? Are we making it worse? Are we treating patients and families in the same way so that ultimately, or in ways that are necessary for each population to ensure that we get the best possible outcomes? And then what is it that we're doing to kind of like follow through with these patients? This is something the Vermont Oxford Network has been really interested and then has sort of led. We are trying to follow their lead to kind of think about, okay, care for these infants doesn't really just end here, like at the doors of the hospital when they're discharged, but the patients go back into their environment, and what can we do to ensure that environment is optimized to ensure long-term optimal neurodevelopmental outcomes. All right, so if there are disparities in the NICU, what might be mechanisms for it? And Elizabeth Howell used to be in New York, is now at CHOP, is an obstetrician, has done some really fantastic work in the whole health equity space and really leading. And she's developed this framework that I think is just really excellent. And so when you think about how disparities come about, there's kind of two different pathways. And I think one of them is that the patients might be kind of segregated into hospitals where care is poor. And the reasons for that might be manifold. So, safety net hospitals may have problem delivering the same level of care because they may lack the necessary resources to provide that care. And the second pathway really would be thinking about patients within a given NICU. Are they receiving the same type of care? And so what we did is we kind of looked for evidence of both or either of these pathways. So here's a study from Elizabeth Howell, and we've replicated this in California. I won't show you that data, but I'll show you hers because I think it's been really just kind of leading work. And so she's kind of looked at all these NICUs in California and kind of ranked them according to a neonatal morbidity mortality index. And as you can see, like sort of the best performing hospital here is almost sort of 6 times different in terms of their outcome, risk-adjusted outcome, and then the worst one. So vast variation. Of course, there might, it's risk-adjusted, but there might still be like unmeasured confounding, et cetera. But nevertheless, vast differences here. And then, like through some additional statistical analysis, she was able to show that 40% of the Black-white disparity and 30% of the Hispanic-white disparity was explained, the overall disparity was explained by the birth hospital. So location of care was a major driver of the differences in outcomes between these racial ethnic groups. Here's another study from the Vermont-Oxford network. It's statistically a little bit kind of difficult to explain, but these are called Lorenz curves. Essentially, if there was no sort of intentional differential segregation of patients across hospitals, then all of these lines for different racial ethnic groups, Black, Hispanic, and Asian, should lie on the diagonal here. And the fact that they're so substantially below the diagonal means that there's a segregation of these groups into different hospitals. Now, it's kind of when we think about kind of differences in outcomes, what we do find, and this is national data as well, that we like from Vaughan data where we worked with them, we looked at differences in process measures and differences in outcome measures between racial ethnic groups. And then we had this composite measure, which is called the baby monitor. Can talk about this more if you guys are interested, but essentially like puts together a number of metrics that like groups of experts feel like are a good reflection of quality of care provided in a NICU. And so on process measures, you see this wide like negative difference compared to sort of like white patients, which is sort of the baseline at 0, right? And the confidence interval like doesn't overlap, so significant decrease here in process care for Black babies, as well as for Native Americans and for Asians, which might actually you might find somewhat surprising. But then in terms of outcomes, actually looks quite different, right? So like African American babies often do better gestational age adjusted. And then the composite, well, sort of what composites do, it's one of their problems is that they can kind of obscure these differences between some of the individual measures. And I'll show you the individual measures here, what kind of goes into these things. So here are some of these processes, like any human milk at discharge, substantially lower. No, like this is hypothermia, and these are called no because they have to, for the composite, they also all have to go into one direction in order to put them together ultimately. So hypothermia at birth substantially worse, antenatal steroids lower, and the eye exams as well. But then in the outcomes, infections, there's infection rates borderline here, but like many of the other outcomes, actually substantially like better. So more to be learned. So people have multiple suggestions where they think that this might, like what we might be seeing here. But it's certainly not sort of like a uniform picture. But concerning that some of the processes which are kind of directly under the control of providers are in this worse area. All right, here's another example of disparities within hospitals. And this is from my own institution, so airing my own dirty laundry here. This is access to skin care for patients who speak English versus those who don't. And as you can see, this is kangaroo care, skin-to-skin care. The time for English speakers is almost double than it is for those who don't have English as a primary language. And this is adjusted for frequency of presence at the bedside. And like what's going on here, right? And so there's the barrier of the translator and all of these things. But there's like it's probably there are multiple factorial things going on. If you guys are interested, we can discuss this more at the end. But important to know that there are sort of distinct metrics that we can look at within a NICU, and we find disparities that we need to work on. All right, here's like somebody stands up and says, no, like at my place, we treat everyone the same. And so we actually did a qualitative study in which we asked respondents and they're all neonatologists, nurses, some parents, and nurse practitioners, etc., who responded to whether or not they had experienced themselves and a situation in which a disparity occurred. And the first thing to kind of understand, these are over 300 respondents, and I love this paper. It's by Krista Stigertson, who's a social scientist, who's a postdoc with us. And maybe of all the disparity papers, it's not so much the quantitative ones, but I think really if you have time to read this one, go ahead and read this one and look at all the stories that look at the stories which we published in the supplement. And as you go through the individual stories that people mention, I feel like you will see that like many of those you might have already experienced yourselves as well. And so these things are actually quite widespread. So when people think about disparities, it's not just race, ethnicity. Language barriers were the most frequent ones mentioned, but there were many others like class and immigration, and or sexual preference. And so these are all of these little icons overlapping Venn diagrams here of disparities. But then there were kind of three sort of major types of disparate care that led to suboptimal care, and then there's sort of one that led to privileged care. Whether that's optimal or not, I'm not quite sure. But people in certain situations receive sort of like privileged care. Anyway, so the ones with associated with suboptimal care were the vast majority, and we ended up dividing them into three different categories: neglectful care, judgmental care, and systemic barriers. So neglectful care was where like NICU staff ignore, avoid, or neglect family needs, like breastfeeding support, like maybe or skin-to-skin support, when that's just considered too difficult or unpleasant, or the obstacles are considered too great to overcome. And there's judgmental care, where staff evaluate a family's moral status based on race or class, immigration, and then circumstances or behaviors are judged more harshly. Discrimination occurs through staff attitudes or resource allocation. And then finally, systemic barriers where staff are either unable or unwilling to address barriers families face, such as transportation, childcare, housing, employment, etc. And I just wanted to give you like two examples of these, of the many stories that are out there that we received from respondents. So here's one. This is just a general observation. When I worked as a charge nurse, nurses tended to just ignore parents who did not speak their language. Often the use of a translator did not occur daily for education and updates. These parents would have to sit by their baby's bedside and wonder how they were doing. These parents did not get the opportunity to interact and bond with the baby as a result. So I showed you the skin-to-skin result, and you can, like, this kind of fits exactly in this category, right? And there's judgmental care. I see this all the time. The way we treat Black moms is definitely different than how we treat white moms. Age plays a factor too. Young moms are judged very unfairly. One Black mom was judged very harshly for being late for a feeding, even though she had a long and challenging transit ride to get to the hospital. A white mother who was late on the same day was greeted with sympathy. So really kind of concerning stories, but interesting that there was not a single story that told us of like the differential treatment of infants. It was all kind of geared towards the families. And so let me kind of tell you a bit what we're trying to do in California to address these different areas. And so I kind of listed them kind of back here with regard to sort of the main things that we do to kind of address quality. So for audit and feedback, I'll show you some examples. We developed essentially family-centered care metrics, because family-centered care, that's how within NICUs differential treatment kind of raises its ugly head. We've developed dashboards so that like all of our hospitals can see how they're doing with regard to health equity on racial ethnic basis, and we've now started also on a language basis. Quality improvement, there's a lot of activities going on. We have a toolkit on families who prefer another language than English, and it's called the NELP toolkit. You can if you have the slides, you can kind of click on this and find it, or you can find it on the CPQCC website. It's available to anyone. It's a really fantastic toolkit. There's a lot of collaborative efforts going on. We currently have a collaborative effort with SafetyNet NICUs, so where we're trying to address the sort of between NICU disparity, and really try to uplift hospitals who kind of care for patients with the least resources. We will be starting a health-related social needs collaborative, it's called Care Collaborative, this fall. So this is going to be another kind of effort to think about care transitions, screening for social determinants of health, and referral of patients. Higher Skin follow-up is trying to do a lot of telehealth efforts. It's difficult for many families to just make it to Higher Skin follow-up clinics, and so kind of driven a little bit by the pandemic as well. These telehealth efforts have been sort of flourishing and been able to address some of the health equity issues and follow-up. The CMQCC is doing, so the maternal side, they're doing a lot of work on improving respectful and equity-centered obstetric care during labor and delivery. This is something that's going to be released nationally relatively soon, and you could also look at that if your hospitals are interested. Then we're doing a lot of like annual meetings, webinars, training modules in our QI training modules that focus on health disparities, and and you could either join these or look those up on our website. We have a disparity tip sheet that was informed by our families. There's a statewide family advisory council that CPQCC has. So a lot of efforts going on there. And then in research, there's a number of efforts also to try to support efforts to reduce health disparities. Let me just give you a couple of examples here. So this is like measuring family-centered care. How do we do this? Like ideally, we'd like to get direct feedback from families and surveys, but we don't have access to families directly. We just get our data directly from the hospitals in a de-identified fashion. So we have no way to contact anyone. And so, like, how can we? So we developed essentially an expert panel and came up with metrics that we already are collecting in the medical record and that might be reflecting indirectly sort of family-centeredness of a unit. We ran sort of a formal evaluation process of these metrics, kind of ranked them, and you can kind of see like a list of metrics here, and then sort of the red ones are then the ones that kind of were like the highest ranked and were covering different domains of family-centered care that we extracted and defined, and then we invited NICUs to kind of participate in measuring efforts. And so this is like one of the new metrics that will probably like this year we'll bring to the entire 135 NICUs to collect. It will be like the days to first skin-to-skin care. And you can kind of see from the hospitals that have participated so far, there's quite a bit of variation. I mean, there's like one hospital is on skin-to-skin care, and this is not just like a hold, this is like a real skin-to-skin transfer. They do this mostly like sort of right at birth, whereas like, another hospital takes like almost 3.5 weeks to do so. So this, like, we feel like is a good metric, at least sort of early on, to take a look at family-centered care. And we have like priming with oral colostrum, that's sort of another one, and then a social worker visit. This metric has not performed well. There's a law in California, essentially, the social worker has to see a family within 48 hours, and that's kind of exactly what we do. Almost everyone sees patients within 48 hours. So I think we'll retire, like one of the things we do is we don't want hospitals to collect things that are not useful, so we'll retire this one, but we'll keep these two metrics where there's opportunity for improvement and variation across hospitals. Here's an example of a health equity dashboard. This looks at, like, we can look at this in different ways. So these are safety net hospitals kind of combined, and you can kind of see challenges for our safety net hospitals. And essentially the way that this is done, there's like rows of outcome measures and process measures that you can kind of look through, and you can use different time periods in which you'd want to look. And then we kind of highlight the highest performing and the lowest performing group on the various measures to give NICUs kind of a sense of where they might have opportunity to improve. And these things tend to like motivate action. We have a health equity committee as part of our quality committees, and here are sort of some of the things that we're working on. I kind of mentioned some of this, like the maternal side has this equity hospital action guide. They're also working on maternal mortality, on maternal anemia, which is a big equity issue, and then a low-dose aspirin in the case of preeclampsia. So all of these things are going on the maternal side, and then on the neonatal side, we had the toolkit that I told you about, the social determinants of health, and the safety net collaboratives, work on transition to home, and then high risk infant follow-up is doing a bunch of work as well. So we're trying to really like get into all of the different areas where we touch these patients to try to help them. And here's just an example of our safety net NICU work. This is currently kind of ongoing. We're lucky and grateful to NIH, at least for now, that we have funding for this. Who knows these days? But essentially, was really quite interesting when you looked at safety net hospitals in California. This is sort of a ranking of their performance on this composite indicator, the baby monitor, as I showed you, and it's and then there's another metric here, survival without major morbidity. And you might have thought that like most of these hospitals are just kind of like lower performing hospitals just based on the kind of population they serve with the low resources they have. But actually there's some of them who are really, really good, right? Like top decile kind of providers. And many of them doing like many more doing like quite well. And actually, if we took this hospital out of our data, which of course we can't, but without this hospital, there would be no statistical difference between safety and non-safety net hospitals in California, which is pretty astounding. But we wanted to try to sort of understand what's driving the differences here. What's different between this hospital and that hospital, and can we help that hospital learn from these hospitals up here or those other hospitals that are maybe struggling a bit more. So we were looking like those hospitals, like safety net hospitals, they asked us to work on breast, any human milk at discharge. So that's what we're working on. So as a group, they do have a challenge compared to non-safety net hospitals. And this is just preliminary work. We're right in the middle of this right now, and then a lot of this data is like incomplete, as some hospitals have not even really started collecting data, and others just have like starting to get going. But this is sort of a baseline data, and there was even some improvement before we started, and like we just kicked off in June, last June, and so this is sort of our currently available data. But essentially, we're working with all of these hospitals to think about their populations and how to move the needle on breast milk feeding throughout the birth hospitalization, which starts early, but then also goes through the time. And Nick Parker has shown this that like at a month of the stay, there's typically a drop off for across different race ethnicities. So they all kind of start, at least in Massachusetts, where she has done this work, they all start at the same level. But then there's like this drop off at a month where a lot of people have to go back to work and things like that, and social issues that maybe prevent people from continuing to provide breast milk. So trying to address all of those kind of things. This is just an example of our disparity tip sheet. It was developed by really a family advisors on how to get started on family-centered care. There's sort of we developed a sort of change paradigm that you could think about if you want to work on these issues. We've published this. You can look it up, and gives you sort of different opportunities to think about supporting ways to support your NICU. Research, I think this is a really interesting area. I'm just checking the time. We got about 20 minutes. That sounds good. This is a really interesting area. Like, how do we reduce disparities, right? What is actually effective? And so, like, should we use, like, we're QI organizations, so we're believers in quality improvement. And I'll show you some data on why I think that this is actually a really effective way to address disparities. And we can have a conversation about like, what, how to do it. So there's like a technical kind of approach versus an adaptive approach where we think about how do we kind of change hearts and minds among people. And if we manage to do that, is that going to be a necessary and effective way to address certain topics, issues? All right, so here, this is an example from our maternal colleagues. This is a sort of statewide collaborative on severe maternal morbidity. This is largely driven by things like maternal hemorrhage. Other things, but maternal hemorrhage is like the big one in this one. And so they started this collaborative. There was no equity aspect to this collaborative. This was all about standardizing maternal hemorrhage, having hemorrhage cards ready, measuring blood loss during delivery, essentially being ready and prepared to intervene. And And before the collaborative, this is all post hoc analysis, like, once we kind of looked at it by different race, ethnicity. Before the collaborative, a large disparity here for Black women with regard to severe maternal morbidity. After the collaborative, compared to all or compared to white, whichever you want to look at, so this was the initial difference here. After the collaborative, still a difference, but much, much smaller. So a big reduction in disparity here without any focus really on, on it. So it's just, this is like a technical improvement that benefited the population the most, that initially was sort of the worst off. And there's been some other examples, I think, where that's happened. So in necrotizing enterocolitis, we've seen like a narrowing of the disparity over time. As I showed you earlier, that this is necrotizing enterocolitis has been reduced by almost 50% since like the late 2000s. And some of this is driven by breast milk feeding. And half the effect of the improvement in necrotizing enterocolitis was attributable to breast milk feeding. And you can see that has gone up in like all different race ethnicities over time, with all the efforts that that hospitals have put into this. But again, like there's been sort of like just the strongest kind of signal for improvement essentially has kind of come here in the Black community. For the Black babies. This is data from Vermont Oxford, kind of like this is, shows it in a different way, but so this is like national data, and also kind of similar story as in California, essentially. And this data from the neonatal network. Of course, this is only 16 hospitals, academic hospitals, so this is not as much of a community look at it, but and it may be a little bit more difficult to understand kind of what's going on. It goes up and goes down. I'm not so sure what to make out of these data, but the population-based data seems to show a clearer picture here. ROP is another one where really there's been an improvement here for Hispanic babies compared to the other race ethnicities over time in California, just based on sort of like improvements in care. The gap has narrowed overall. And so, those are just some examples of where really there were no sort of race-specific efforts made, but just kind of quality improvement efforts that have reduced variation and kind of brought all the groups kind of closer together, which is kind of what we want to do. All right, so I think I'll wrap up with this. Like, we don't practice in a social cocoon. There are biases in our NICUs. There's differences in which we treat families that we need to address. So these disparities exist, and we need to not think or wish them away, but we need to think about how to address them. I think education is necessary, but I don't think it's sufficient. I think QI methods are actually like effective in reducing disparities and warrant strong consideration as a tool to actually make a change. And then we need to bring in families. Like family-centered care is critically important. We need to not just think about how we measure family-centered care, but we need to bring them in and learn from their wisdom so that we can actually learn how to improve and serve them better. And I think I will leave it here for some time for questions and discussion. I'll leave you with this. Oh, this is still the time when I was on Twitter. I haven't been there for a long time. It's called X now, so don't try to tweet me.
Wow. Thank you so much, Dr. Prophet. I'm always just really struck by the elegance of your work, how you're able to take these large population data sets and make sense or give a story to a lot of what we're seeing on the ground when we're dealing with patients and families. So thank you. We have questions in the chat. The first comes from someone who is saying, they're interested in health equity research, but they find it difficult to assess data given that documentation of race and ethnicity is often incomplete or inaccurate in the EMR, especially for those who are multiracial. So, how do you ensure the accuracy of documentation of race when doing this important work?
Yeah, it's a great question. There's obvious limitations. Vermont, Oxford, and CPQCC support the kind of rules that states have for vital statistics, for birth certificates, essentially. So it really is supposed to be the information by the parent directly about their self-identified race, ethnicity, including multiracial. And in California, so we actually in California we collected in CPQCC. We also collected from the birth certificate. We're linked to birth certificates in the state, and so we can compare actually what we get compared to what the state has. And a lot of this work, we end up using the state data as the quote unquote more correct or valid data. Because it's ultimately really typically like the parent that provides that data. Whereas in a NICU, it might be, well, this patient's name is Gutierrez, so I'm just going to assume that they are Hispanic. And so, but we're able to compare it, and the correlation is very high actually between the CPQCC data and the birth certificate data. So I think it's pretty good. The multiracial question is such a great question. We're working on some like an Asian health disparity grant, and and actually the multiracial Asian groups have like really interesting health challenges for NICU baby outcomes. So we don't know where they're from or what's driving that, but it's very interesting that we see this. So there's a lot more work that might need to be done in that range. It's a good question. Like there's obvious limitations on these things. And father's race ethnicity, right? All of this is based on the mother's race ethnicity. So it's like an obvious flaw here is that like the father's race is not really even considered mostly. And when we're talking about multiracial, that's actually the mother saying that she herself is multiracial, but there are like several layers of these things. And in many ways, I mean, I guess as the country is also becoming more multiracial and mixed, these things get ever more difficult to tease apart. So take all of it with a grain of salt.
Thank you very much. I wanted to ask a question similar to one in the chat, but hopefully getting people thinking about our next steps after our conference today, moving forward into our quality improvement projects. How can units start off if we're looking at the data that's so clear in the work that you've done in different collaboratives? How can we help to provide more equitable care as a starting point if we're in an area that really hasn't developed our own programs? What could be a starting point for people that want to move forward and provide better care?
Yeah, that's a great question. I think like it depends kind of like, are you doing this as a system or an individual hospital? Are you using a collaborative? It's always worthwhile just like figuring out do you have any knowledge about what challenges are in your own NICU? Like it depends. So like, what is the population like in your NICU? So something in California, for instance, 50% of our births are Hispanic, right? And then about 6% of our births are Black. And so, like there's obviously both the populations have needs that we need to address, but for your individual hospital, like for a health equity dashboard, for instance, for many hospitals, they don't have enough Black births to even show. any kind of meaningful data because there's just too few patients, right? With regard to Black patients. With Hispanic patients, many of them will. And so but the issues are often very different if you're thinking about health equity between like a Hispanic or a non-English speaking population versus maybe one where there's a lot more sort of historical inequities and racism and those things involved. So it kind of depends. Like first, I think like define your population that you or know the population that you have, which I'm sure you do, and then like figure out like are there already what do you think are the problems that they're facing? Maybe you have a family advisory council. Maybe you can bring some families together and say like, hey, like can they help guide you on like what might be a good topic to address? Do you have existing data around some of these items where you can actually, where you can collect results and figure out like, okay, are we making progress or not? So I think there's a bit of like groundwork to be done, and then pick one problem. If you haven't started if you haven't started, don't pick the hardest thing first. Like pick something that you feel like you'll actually can make a difference in, and then address that and hopefully make it a successful project, and then kind of build upon that project with future ones that might be more difficult. Maybe what I'm showing you around the successes of the technical improvement, those are sort of might be the low-hanging fruit, right? It's like, okay, we can do some technical things and really just decrease disparity, and that's great. It doesn't really address sort of the underlying issues around, racism and those things. But like start with an area where you can make a demonstrable difference, and then kind of build on that is what I would say.
Thank you.
Okay, great. We have another question that's regarding, potential threats to whether it be the NIH
NIH, yeah.
funding,
I
and
figured you might ask about
health
this.
equity work and whatnot.
Yeah,
Do you have any, recommendations or
yeah.
plans for going forward with that?
Yeah, I mean it's so hard, right? We don't know whether the safety net collaborative that we currently have ongoing is still going to be funded over the next couple of weeks. And like most of the grants that I've showed you have a disparity is like an equity aspect and might be canceled. For writing, like with regard to just writing grants, like quite honestly, we're just taking that language out because we think essentially NIH just runs searches on certain keywords. And like we've already heard that like certain proposals don't even get discussed anymore in NIH study section. So, it's great if you want to be a purist about it and say like, well, I'm just going to continue to submit it. But if they're not even discussing certain proposals with this language, then like it's a lot of work to put together a grant like this. And you know, so then you have to kind of think like, okay, what is it that we ultimately want to do? We want to like continue to work and improve mothers and babies' lives, and kind of like how can we do it in a way that will kind of keep the work out of the ideological crosshairs in some way, just it's difficult. So we're certainly thinking about this. Like so far we haven't really made wholesale changes, but we're also being open-eyed about that. Like just continuing as currently is probably not going to lead to funding support. Now we could do some of the work that we do just because we think it's the right work to do, and then it's kind of funded in part by our membership. But even there's concerns about membership because the hospitals might might also suffer financially, and so they might no longer be able to, pay additional dollars to even participate in improvement collaboratives. So yeah, it's going to be difficult. I think sort of a focus, like what we thought about we would do is to focus on data, and focus kind of on improving sort of large goals that kind of like nobody can be against. And we've heard from colleagues. We have a group. It's called the Big Five state, or the Big Five state, but we have regular meetings with those, and they're like New York and Florida and Texas and then California and Illinois are kind of part of those, just like the Big Five like population states. And our colleagues in Florida and Texas are kind of like gone through this already in the past and sort of had to deal with all like changing language on websites and things like that. But essentially, like they've sort of said, and we kind of arrived at kind of similar thoughts in like ourselves, is can we focus on we're improving the health of mothers and babies, who could be like against that? And so you just kind of frame it slightly more broader, and then underneath that, can you still do like important work to understand, which groups may need specific additional help to ensure that we're improving everyone's outcome. And honestly, it's sort of like the way that I came into this work is because I'm more like a quality improvement guy, right? Like and like it's all the variation, like disparity is a kind of unwanted variation in the data. And so can we like if we reduce all the variation that we see in the data, I think we're making good progress on kind of what we're charged with as an improvement collaborative. Um, but it's ultimately somewhat unsatisfying, and sort of infringements on speech, I think, are not a positive thing, um, in any direction, probably. So yeah, it's a difficult time to. We'll see as it works its way through the courts. Like we're not like reacting too much, but trying to be ready to like if something comes down. So it has big implications for us as an organization because we have a lot of funding tied to like state and federal grants, and yeah, we'll have to see what happens.
One of the unifying themes that we've seen from really start of this conference today is the importance of family engagement. Have you come across any tactics or that you can share with us related to how do we make sure that our engagement of families is representative?
Yeah.
There's a tendency within NICUs and just human nature that we tend to you know, align ourselves with people who are similar to us. It's rare that we would seek out the quote unquote difficult parent and ask them to join our family advisory council when they
Yeah.
probably have one of the most unique voices to contribute. So, have
Yeah.
you come across any tactics that help you in terms of engaging a really representative group of parents to work on issues in the NICU?
Yeah, it's a really hard thing to do, right? So we've done this like we have a family advisory council for the state, and we've gone through like recruitment. We're very intentional about recruiting, a diverse group of families, including some that didn't speak English. And even though we're finally like we're able to recruit them and had a translator kind of like ready for like live translation of our meetings, they then ended up like never actually showing up to the meeting. And so it's very difficult. It's very difficult to do, right? But certainly like some of our families that are like low income are really dedicated to the work. I think what is really important for them is to think about not just using their time as volunteers. I think one of the key barriers is that we need to reimburse their time in some way, like most of the time, that's probably money. but it can be other things that might be of importance to families. It could be presenting at meetings or, things like that. There's community groups of families like with diverse backgrounds that well, maybe Kimberly is on the call here. She can kind of talk about this probably better than I do. But you can try to reach out to those and sometimes get kind of leaders of community groups um, who sort of have like a demonstrated interest in doing this and a will. Of course, like many of those also, like Kimberly, are like highly trained, and not necessarily representative of all populations. So it is a difficult thing. But once you bring them in, I think it's very important to understand that, they face many challenges oftentimes in their own lives and they may not make it to all the meetings, and they require a lot of mentoring. I think before, it's a very traumatic thing for a family member. And again, like Kimberly is usually a much better expert than me on this, but they often will revisit their own trauma like many times, telling their story, thinking about, or if anything comes up, they're thinking about their own baby and what they went through. So it's very re-traumatizing and difficult. So being aware of that, kind of coaching them through that and mentorship and sort of a plan ahead of time, I think is really important. It's really important for all families, but maybe specifically also for the ones that face a lot of like social barriers as well. And then, maybe there's other things you can kind of do for them if you don't have the money. Maybe you can help them connect them to, services that they might not know they have access to. So thinking about ways that you can kind of support them as well, it might be helpful. But it's a very hard thing to do. Um, in California, we only have about 25% of our hospitals have family advisory council. I think it's pretty consistent with Vermont, Oxford. It's a very difficult thing to do. The vast majority of neonatology happens in smaller hospitals. And mostly it's just kind of like the larger children's hospitals that have these family advisory councils. Not only, but in many cases. So it's sort of a question of whether we need like a different like system actually for those hospitals to have access to family advisors. We've been thinking about it sort of as a state. Could we have like a family advisor where hospitals could come to us and say like, hey, we're doing this work on this project. We want like a family voice on this. Could you connect us to somebody or and figure out the specifics on how to kind of organize that. But finding like maybe resources in that way might be a better way to get more hospitals, family input.
Wow. Thank you so much for a great talk. And I mean, your work really is inspirational. Here at our own center, we are working to build a dashboard so that we have a strong quality improvement center here, and to build a dashboard so that we can include equity as part of our quality, looking at our quality metrics.
Mhm.
And with that, we are going to move to a break. We will resume at 1:15. So please, everyone, take this opportunity to stretch your legs and take care of any needs that you might have. And we will begin promptly at 1:15 with our next set of panelists who will be speaking about social determinants of health in the NICU. Hmm. Good afternoon, everyone. We're going to resume our program, and it is with great pleasure and pride that I introduce our next two speakers who are work colleagues. The first is Dr. Kais Kareem, who's an attending neonatologist here at the Joseph Sanzari Children's Hospital. He completed his neonatology training at New York Presbyterian, Morgan Stanley Children's Hospital, where he also served as chief pediatric resident and chief neonatology fellow. His interests include health equity in neonatology, equity-focused implementation, science and quality improvement, social determinants of health, and medical education. He most recently conducted qualitative research using implementation science methodology to gain insight from stakeholders to examine the feasibility and acceptability of standardized SDOH screening and referral intervention and to identify factors affecting implementation outcomes. He is joined by Melissa Giuliano, who again I have the pleasure of working with in our NICU. She's a licensed social worker with, more than 7 years of experience, currently working at Hackensack. She's been with us for the past 5 years. She covers our NICU, labor and delivery, postpartum, and the high-risk antepartum units. She's passionate about supporting families during life-challenging events and is dedicated to addressing social determinants of health to improve patient outcomes. Please join me in welcoming my colleagues.
Good afternoon, everyone. Thank you so much, Dr. Island. That was a very kind and generous introduction. I know Melissa and I are both excited to be here with you all. If you bear with us for just a split second, and we can go ahead and share our screen with you. You're able to see our slides, is that correct?
Yes.
Fabulous. All right, good afternoon, everyone. Thank you again for joining us. My name is Kais.
My name is Melissa.
And we today are going to be discussing a little bit about standardized screening and referral interventions for social determinants of health in the NICU, and really how their presence in the NICU can be a marker of the health of our NICU with respect to how we support our families. Our outpatient colleagues do a really fabulous job at this, and as these interventions have really become increasingly common in inpatient settings, I really think we have to challenge ourselves and think about not just how to check a checkbox for the presence or absence of these interventions within our NICU, but really challenge ourselves and ask ourselves how we can do these interventions well in partnership with and in service to our families. We have no financial disclosures to disclose. We, of course, however, will disclose that our lived experiences and identities inform our scholarship and passions within medicine. In terms of outlining what we're going to be discussing today, we'll share a little bit about some of these perspectives that both Melissa and I bring to the work that we do, define social determinants of health and clear up any confusions as to what that term means, discuss SDOH in the context of preterm births, talk further about NICU infants and social needs, talk a little bit more about standardized screening and referral interventions, and some of the regulatory mandates that exist using this map with 5 stops on our map, and wrap up with some conclusions.
So again, my name is Melissa. I'm a maternal health social worker here at Hackensack University Medical Center. My passion for social determinants of health stemmed from my identity as a first-generation American to parents whose primary language is Spanish. During my adolescent years, I supported my parents by interpreting medical information, assisting with paperwork, and advocating for their healthcare needs. This experience has influenced my work as a social worker, where I continue to advocate for and empower families navigating the healthcare system. I complete safety assessments, connect patients to resources, and counsel patients during transitions or high-stress events, including fetal demises.
And as I mentioned, my name is Kaisen. I'm one of the neonatologists here at Hackensack University Medical Center. And I'm thinking about my own biases that I bring to my work and clinical environment. I am a neonatologist. I am a refugee. My family and I are refugees of civil war from Afghanistan. And although I grew up mostly in the suburbs of Washington, D.C., from age 5 onwards, I have been in New York City for about 15 years and New York State for 20 years. So this very much feels like home now. Farsi is my primary language, English is my second language, and I also have the fortune of being proficient in Spanish. I'm the first in my family to go to college, which is why I have my alma mater listed here on this slide. I graduated from Cornell in 2009. I'm additionally a member of the LGBTQIA community and have some of the interests that Dr. Island highlighted earlier. So to jump in, start broadly, as we all know, as folks who care for children and care for the families of children, children are uniquely and particularly vulnerable population from a socioeconomic and psychosocial perspective. Children are overrepresented among the nation's poor. So although children represent about 23% of the US population, they comprise about 1/3 of all people who live in poverty. And decades of research that I won't go through here have demonstrated the deleterious impacts of childhood poverty and material hardships on neurodevelopmental and health outcomes of children over the lifespan. This figure here simply demonstrates that the childhood poverty rates over about the last 15 years. And what you can see here is that although there were some marginal improvements prior to COVID, we really are seeing a resurgence of childhood poverty rates back to pre-COVID numbers as government financial support cash transfers have waned. And most notably, and I'd be remiss if I didn't highlight this, the disparities that exist among different racial and ethnic groups, minoritized groups facing greater childhood poverty. And to really be able to discuss further and address these disparities, I was hoping to specifically define what social determinants of health are. This term itself is a neutral term. It is not negative as it is oftentimes perceived, and it's not necessarily positive. It's a neutral term, but this definition that I share with you of SDOH is from Healthy People, though the World Health Organization has a nearly identical one. And social determinants of health are defined as the conditions and the environments where people are born, live, learn, work, play, and worship and age that then affect a wide range of health functioning and quality of life outcomes and risks. So broadly, you can conceptualize these determinants into 5 categories, 5 buckets of education, economic stability, social and community context, healthcare access and quality, in addition to neighborhood and built environment. And to look within each of those buckets, specific examples include safe housing, transportation and neighborhoods, racism, discrimination, and violence. And in 2019, the American Academy of Pediatrics in their policy statement actually named racism as a social determinant of health that impacts significantly the health of children and adolescents, education, job opportunities and income, access to nutritious foods, polluted air and water, so on and so forth. Of course, though, a focus solely on quote-unquote determinants really fails to recognize the distribution of social determinants of health among the population is not random. And we know that social, economic, and political systems distribute these quote-unquote determinants inequitably across the population. And so Black, Indigenous, and other people of color are more likely to experience reduced access to healthcare, receive care in lower quality hospitals, and Dr. Prophet shared some of that data with you just a moment ago, live in neighborhoods with more risks and fewer resources, and additionally have increased exposure to environmental pollution. Additionally, many of these communities are overcriminalized and have diminished access to employment and wealth opportunities. And the inequitable racialized distribution of social determinants of health in the United States really highlights a prominent role of racism as a key factor in these social determinants of health. To take this one step further, we can think about the downstream impacts of exposure to either positive social determinants of health or adverse social determinants of health. And so with exposure to positive social determinants of health, you can think of it as cultivating social assets. So for example, housing stability, stable employment, access to clean water, and access to high quality education are all examples of social assets that have been cultivated by positive exposure to social determinants of health. However, when thinking about exposure to adverse social determinants of health, that is associated with social risks and social needs. And so social risks can be thought of as unmet basic needs, such as housing insecurity, food insecurity. And social needs are whether or not a family actually requests for support or has a perception of a need around one of those social risks. So, for example, housing insecurity is an example of a social risk, and an associated request for housing need by a family is an example of a social need that results from adverse exposures to social determinants of health. So to bring this a little bit more into our world of preterm birth and the NICU, I really like this framework by neonatologists in Boston. Burris et al. Proposed this framework of and this is in 2019. They proposed this framework of microenvironmental and macroenvironmental factors that shape the likelihood of preterm birth. And so microenvironmental factors can include behavioral factors where there's an element of individual choice that can be made. So this includes things that we commonly think of and receive counseling for, which includes smoking and diet. Macro environmental factors really are the ones that I'm interested in the context of this conversation. And those include social and physical exposure, environmental exposures, such as neighborhood violence, air, water pollution, exposure to heavy metals, and so on and so forth, that relate to the social determinants of health, the adverse social determinants of health that I highlighted a moment ago. Both micro and macro environmental exposures can affect an individual pregnant person's physiology and alter the likelihood of delivering preterm. And what I think is important for us to consider, and important for me and important for the authors of this paper, is that the macro environmental factors likely play a much more significant and underappreciated role in population level disparities. And as an extension of this, we know that racial and socioeconomic disparities exist in preterm birth and neonatal morbidities and mortalities. And again, Dr. Prophet mentioned this a moment ago, so I'll touch upon them very briefly in our conversation. We know that our patients in the NICU and their families are quite vulnerable with significant medical and social risks. Broadly, about 10% of births in the US are preterm, and this percentage has not gone down. This percentage has actually gone up over the last, has continued to rise. And these preterm births occur disproportionately among low-income parents and parents of color. So two specific examples. In the United States, Black infants are 50% more likely to be born preterm and 3 times more likely to be born before 28 weeks gestation. And additionally, Black preterm infants experience higher mortality rates and higher readmission rates compared to white preterm infants. This is some data from the March of Dimes that I think is really impactful and important to look at. And I included here figures from the United States in addition to the Jersey figures. The trends are quite similar between the two, and additionally, I did not include New York here for some of our New York folks who are joining us, but the New York trends are quite similar as well. What you could see here are the preterm birth rates from 2021 to 2023 by race and ethnicity. Then I previously had this slide with older numbers, and the numbers were pretty similar. But during this time frame, what you can see, as I mentioned a moment ago, is that the white preterm birth rate is about 10%, but the preterm birth rate among Black birthing parents is about 50% higher at around 15%. And additionally, you can see that among other racially minoritized groups, including American Indian and Alaska Native, that there is an increased risk of about 25% for preterm birth. And these patterns, again, pretty similar in New Jersey. When looking at so we talked about the preterm birth rate, and I also talked about morbidity and mortality. So let's look at morbidity. Low birth weight by race and ethnicity. You can see here in the United States and New Jersey, very similar patterns, with the white population having the lowest rates of low birth weight, so 7.1 and 6% respectively. And then you can see that those numbers are almost double in both the United States and New Jersey. And it's significantly increased among all other racially minoritized groups as well. And lastly, and I think most stark, but this has information for infant mortality rates by race and ethnicity. And you can see that the infant mortality rate in the United States is about 4.4%. In New Jersey, we do better, and it's about 2.5%. But in looking at the disparity, so the difference, you can see that among the Black population in the United States, the infant mortality rate is over 2 times higher. And in New Jersey, it's about 3 to 4 times higher, which is really important for us to keep in mind. And the trends, again, between other racially and ethnically minoritized groups are pretty similar between the United States and New Jersey. So that we know that in addition to differential care, low-income families can experience both long-term financial burdens such as housing and job insecurity, in addition to short-term financial burdens that stem from prolonged hospitalizations of their infants in our NICUs. And these financial burdens are really far-reaching. This includes parking, transportation, limited pay leave, childcare costs that affect parents' ability to visit the NICU and engage in caregiving activities. And the reason I bring that up and emphasize that is because we also additionally know, as so many of our wonderful speakers that talked about earlier today, that parental presence in the NICU is so important for so many reasons. Them seeing their children, not visiting their children, is really critical for a lot of improved neurodevelopmental outcomes in the future, and has been demonstrated to have positive impacts on many other short and longer term health and developmental outcomes. Additionally, our parents of our NICU infants are juggling a lot of priorities, especially immediately after the birth. Birth parents are recovering from the birth themselves. We know that these families are at higher risk for stress and anxiety, and many of them experience postpartum depression more so than their term counterparts or families who are not in the NICU. And additionally, and I think something that we oftentimes underappreciate, but we anecdotally discuss during our interdisciplinary rounds, is that many of these hardships that our families face may change or evolve over weeks to months over very prolonged hospitalization. And this is not well elucidated in the literature, but is something that certainly we all have heard in caring for families who come to the NICU. This figure on the right, and thinking about not just what are the problems, but how do we tackle them. This is a figure from Dr. Profit, and he shared a version of this just a moment ago. But in thinking about equity-sensitive family care, there are a multitude of different things that different tools that we have to promote equity-sensitive family-centered care. But two of these are professional and standardized screening of social determinants of health. So the standardization of that is really key, in addition to support for transportation, food, and siblings. So for social needs. And honing in further into our domain as pediatrics and neonatal care providers, the American Academy of Pediatrics, our governing body, has acknowledged the significance of social determinants of health on childhood health and development. And in 2016, the AAP in their policy statement recommended universal screening for adverse social determinants of health and delivery of referrals for community resources for unmet basic needs within all pediatric clinical care, and this includes the NICU. They reaffirmed this in 2021 as well. Additionally, various other professional organizations have made similar recommendations. And in 2024, CMS implemented a mandate for screening for SDOH for all inpatient adults. And the reason I bring that up with a bunch of folks who are interested in the care of babies and families in the NICU is that this includes screening for SDOH for our birthing parents who deliver their infants in the hospital. Additionally, as Dr. Island had mentioned previously, as a part of the JCAHO Health Equity Certification, there is also a requirement for standardized SDOH screening and referral interventions. And so we know that that is something that many of our governing bodies and regulatory agencies are recommending. And I think in practice, we can see, and I will share some survey data with you in just a moment, that this does not yet exist universally across all NICUs. And thinking a little bit more objectively on what challenges look like for families of preterm infants and how preterm infants are an especially vulnerable population through at least the first 3 years of life. This data really is nothing compared to the stories that our family partners have shared with us. Some of our keynote speakers have shared with us earlier, but to add a little bit of a different context to their really impactful stories. In this study published in 2022, in the study of 24,000 children aged 0 to 3 of term, moderately low birth weight, and very low birth weight infants, the authors found that compared to term children, preterm children who were VLBW, so the smallest infants, were more likely to reside in households that experience food insufficiency or difficulty paying medical bills, and with caregivers who report financial hardship. Caregivers of these preterm VLBW children were also more likely than term children to be enrolled in WIC and to receive receive food stamps and cash benefits. And these are the red boxes. All of these findings were statistically significant among the VLBW group. And then additionally, compared with term children, both preterm children groups, so with moderately low birth weight and VLBW, had reported worse overall health, and those with VLBW were more likely to have visited the emergency room and more likely to report unmet healthcare needs over the previous year. This is post-discharge. And lastly, with this study, this is a table that demonstrates the associations of household material hardships. And so what that means is, so household material hardships and child health and healthcare, again, among preterm children, and matching for sociodemographic characteristics, special healthcare needs, income, and receipt of public benefits. So controlling for all those very important factors, household hardships were still independently associated with adverse preterm children's outcomes. So those household hardships being food insufficiency, financial hardship, and difficulty paying medical bills. And the specific preterm children's outcomes that are documented here include fair or poor health, which they defined emergency room visits, and unmet healthcare needs. What's not shown here briefly is that the authors performed an analysis of effect modification, and they found that race was a significant effect modifier for the association of preterm VLBW birth and household financial hardship. And so the increasing odds of residing in a household with financial hardship was 2.8 times greater, so almost 3 times greater for Black VLBW children compared to their white counterparts. And additionally, the authors identified a Black-white disparity in difficulty paying medical bills, whereby the association between preterm VLBW birth and difficulty paying medical bills was only significant among Black VLBW children, not among white VLBW children. So we see that unmet basic needs are highly prevalent among the preterm infants, and that these unmet basic needs are associated with actual adverse child and healthcare utilization outcomes. So despite recommendations for universal SDOH screening, I think we can probably all in this talk highlight that this is not the universal standard in all NICUs across the country. This is a survey study that was published in 2022, so just about 2.5 years ago, in which the authors sought to clarify the national prevalence of SDOH screening in level 2 to 4 NICUs across the country. And so they surveyed 500 clinical leaders and received 170 responses. And what the authors found here is that overall, only 23, so not even 1 in 4 of US level 2 to 4 NICUs perform standardized SDOH screening. And the authors proposed QI as a tool that could scale up the implementation of standardized screening processes. And I keep repeating the word standardized, and I think that's really key to the work that we're doing. So we've established the uniquely vulnerable nature of our NICU infants, most notably racially minoritized families and lower income families. We also established that adverse SDOH predispose these infants to adverse health outcomes. And we also talked about how standardized screening and referral interventions can ameliorate some of the adverse outcomes that are associated with adverse SDOH exposure. And we know what the recommendations are from multiple different regulatory agencies and professional organizations. But we know this doesn't happen universally. And I think what's important to consider is, well, what do people who actually work in the NICU think about these interventions? Are they actually happening? Do folks in the NICU who work in the NICU feel that it's important? And so this is where this paper comes in. And I really like this mixed methods paper where there was a quantitative portion and a qualitative portion. I want to see more for the qualitative perspective that they offer. And so the authors of this paper performed this mixed method study among a group in Boston Medical Center in addition to UMass. And from a qualitative perspective, they conducted focus groups of different NICU staff to really understand, 1, the current methods to assess unmet basic needs, and 2, perceived appropriateness of standardized SDOH screening and referral processes. This is before a standardized process existed in their unit. This is a lot of text, and so I'm going to bold the parts that stand out to me. But in their qualitative analysis, they identified 6 themes that emerged, which are listed here on the left, and I'm going to go through 3 of them that really stuck out to me. I have bolded a quote in one of the themes here. This first theme is current methods of assessing unmet basic needs are not standardized and are inconsistently performed and documented. This quote by a physician in their group wrote, I don't think that there's a systematic way that it happens each and every time. There's definitely not a systematic way that it gets documented. The second theme is addressing social needs of families is an essential part of care for preterm infants. And so another physician here is quoted as saying, I think it is an important job to identify if SDOH are there and at least try to address them because it has an enormous impact on more than some of the things that happen in the NICU on the long-term outcome. And the last theme that really stuck out to me was use of a standardized screening tool is feasible and beneficial. A nurse here states, I do think it's great to ask these questions and have standardization. As nurses, a lot of it's discussions of unmet basic needs at the bedside. We'll have a conversation and recognize that they need help from different sources, but we don't necessarily have, this is what we need to ask, and this is where it's documented and that you find out this information. So before we jump over to what these processes can actually look like and go to the map that I had highlighted to in the beginning of our chat, we know that our patients in the NICU are uniquely vulnerable with significant social and medical risk, and that preterm infants born in low-income families who, due to structural racism, are disproportionately children of color, suffer worse health outcomes compared to infants in higher-income families. Standardized screening and interventions for SDOH and referral interventions are important in ameliorating these negative impacts, and there's a perception by folks who actually work in the NICU that this is important as well. And despite the recommendation from the AAP, this is not consistently happening across all NICUs in the United States. I will say that study was from 2022 or in 2025 now, and although more units are doing standardized screening and referral interventions in a way that I can't quantify, but sort of speaking with other folks who do this work, the question really becomes, as I mentioned at the start of the chat, are we doing it? Yes or no, and two, are we doing it well? And I really want to challenge us in thinking about how we can do this well and in service to our families. So this is the map that Melissa and I had created, and again, a lot of this references and resources are actually from the Vermont-Oxford network, so we thank them for their fabulous education around this topic. But we wanted to go on 5 different stops in our map about how to bring standardized screening and referral interventions to an inpatient unit, namely the NICU. And so the first thing we think about is SDOH tool selection adaptation. What are the questions you ask? Why? What tool do you use? There's so many that are out there. Which one do I bring to my unit? 2 is, how do we integrate this into the electronic medical record? Do we integrate this into the electronic medical record? And what's the utility of that? 3, once we do the screening, we certainly have to have referral resources to meet our family's unmet basic needs, to meet their social needs. 4, and after doing this planning, how do we actually bring this to fruition from an implementation perspective? And what are the other factors that we need to consider? And then lastly, which we won't focus on too much here, but maintenance and optimization, which can be addressed through multiple PDSA cycles from a quality improvement perspective. And so I'm thinking about tool selection and adaptation. There are multiple things to consider for tool selection. There are so many different social screening tools that are out there that are peer-reviewed. And I think that it's important to think about the psychometric properties of a tool and the pragmatic properties of a tool. So the psychometric properties are the reliability of a tool, the validity of a tool, how good is this tool in measuring what it's intended to measure. The pragmatic properties of a tool are really the practical things to be considered. So how easy is this to use? How long is this? How many questions is this tool? Is it appropriate for families with low health literacy and low literacy in general? Is this a tool that's relevant to the NICU population? And so the study that I cite here does a systematic review of 21 social screening tools. And this study was published in 2019. And essentially what the authors note is that there are multiple low-cost, multi-domain, low literacy social screening tools that are available. The psychometric data for these tools is quite limited. And so all of this to say is there's no perfect tool And so oftentimes the tool that is easiest to adapt to using in the NICU, so the pragmatic properties of the tool, can be more helpful in bringing a particular tool to the NICU. There are, if you look in the literature, you can find so many of these tools, and oftentimes one of the things I think to consider is there a tool that's already in use in your healthcare system? So what do our outpatient pediatrician colleagues use here? Are inpatient folks here or in your institution using something that can be easily brought over and adapted to the NICU? Is there utility in having this screening done when infants are in the NICU, and if they're following within your academic practice, to be able to trend this information when the outpatient pediatricians are doing that same screening on an outpatient basis? And so that is certainly one thing to consider. The other thing to consider is, and we'll talk about this, EMR integration. There are some tools that may already be embedded within your particular EMR. If you're using Epics, different Epic builds have social screening tools already pre-built into them, and are those tools that we can leverage as a part of standardization of these processes within your unit. Alignment of these needs, alignment with needs of families in the NICU. As an example of what I mean by this is sometimes the transportation question to assess for transportation security or insecurity is phrased as, comes from questions that are oftentimes used on the outpatient side, but to assess for transportation insecurity, do you have difficulty attending medical appointments? Which sounds like a totally reasonable question. However, if you were to ask that question of many families who are in the NICU, that question might not come up as being flag positive by many families. But we, as folks who work in the NICU, know that transportation is one of the highest, if not the most common unmet basic needs, depending on what unit you're working in. And perhaps a more appropriate way to ask that question is, are you able to find transportation to see your baby regularly? And if you were to ask the question that way, in a way that's more appropriate to the NICU population, you may be more truly assessing what it is you're actually trying to assess. And so that adaptability of questions to the NICU population is really, really important. And so what domains are you screening for? A lot of the social risk screening tools cover similar things, but specifically the possible domains that exist are here on the left-hand side. I think a helpful way to think about it is, well, we know that CMS is mandating inpatient screening for all adults that are hospitalized, so are birthing parents. And so hopefully these families are already coming in these parents are oftentimes already coming in, the birth parents coming in with the screen before the baby comes to the NICU. And the CMS mandated domains are housing, energy and utilities, food, transportation, in addition to interpersonal violence. Well, when we were screening families in the NICU, aside from what our OB colleagues have done on the inpatient side in L&D and antepartum, what are the things that we should consider? And this is a figure from Bond that I've color-coded. And so the Bond team is really recommending those 4 top CMS domains: housing, energy, utilities, food, transportation. And then other things that you could possibly consider screening for include childcare, employment, education, material goods for babies as well. And these all may have different degrees of urgency. A family who is housing insecure and does not have a housing stability, that may be more urgent than parents who are desiring greater educational opportunities for themselves. And also we'll talk about that in a moment as well. This is one example of a screening tool. This is called the Thrive tool, and I won't go through all of it, but mostly you can see that the different domains they screen for have these beautiful little infographics right next to them. But what is really important is this disclosure statement. So this disclosure statement is really critical because it helps to normalize asking all patients, regardless of sociodemographic characteristics, these questions with the explicit shared intent of helping families. Families sharing these social needs, this can be really, really challenging and a lot to disclose for families. The evidence has shown that there's a lot of shame for some families associated with having unmet basic needs or social needs. And additionally, some NICUs report that some parents fear their children might be taken away from them if they disclose unmet basic needs. And so this disclosure statement is really important to help to mitigate those fears and concerns.
So we've learned about why screening for social determinants of health is important. SDOH has a profound impact on the outcomes of our NICU patients. The goal is to improve family support, reduce stressors, and facilitate referrals to community organizations I am staffed by the Care Coordination Department. Given the size of our hospital network, standardization has been a top priority. With that being said, the SUH screen is completed by all inpatient care coordinators for patients above the age of 18. We do, however, incorporate topics that are specific to the NICU, such as whether they have supplies for their babies or the risk for postpartum depression. There are a few reasons why we use the assessment template that we use. This includes a comprehensive scope. It addresses a broad range of social, economic, and environmental factors. It's also practical for NICU settings. It can be completed in a timely manner, given this is a fast-paced environment. And it's culturally sensitive. The questions are respectful of cultural diversity and adaptable to various populations. Our goal is to administer assessments within 24 hours of delivery, as early identification of risk factors reduces the chances of rehospitalizations or developmental delays. However, we are sensitive to each baby's needs. If a baby is critically ill, we will withhold from completing an assessment and instead assess for behavioral health needs and social support. Now, there's a few key areas of focus. Housing. We screen for housing stability because unstable or inadequate housing can directly affect health outcomes. Families without stable housing may have difficulty keeping medical appointments or providing a safe environment for a newborn. Identifying these families allows us to connect them with housing resources early in their NICU stay. New Jersey's 211 is a free confidential service that connects families with community resources. They can assist with providing emergency placement in shelters and promote access to affordable housing. Food insecurity is another key area we assess. Babies, particularly preterm infants, need proper nutrition to thrive. If parents are unable to afford healthy food or face other barriers to accessing it, this can impact their baby's development and health. We refer families to local food programs to ensure they have access to the nutrition they need. A great majority of our families participate in Women, Infant, and Children, also known as WIC. We ensure that each eligible patient is discharged with a WIC referral form before they leave the NICU. While in the NICU, our breastfeeding parents are able to enjoy 3 meals so they don't have to go without a meal during their visits. It can be costly eating out for all meals. The lactation nurse and the social work team often collaborate with this as to ensure breastfeeding parents are able to nourish themselves nutritionally and to continue to produce breast milk. Sorry, no worries. Financial and employment stress. So financial strain often accompanies a NICU stay, and families may be missing work or struggling to pay bills. Addressing financial stress early can reduce anxiety and improve a family's capacity to focus on their baby's care. We refer uninsured parents to the Financial Assistance Office for insurance screening. Parents are screened for emergency Medicaid, which would also cover their own hospitalization on labor and delivery and mother and baby. They also assist with enrolling the baby in Medicaid. We refer parents who are expected to have a long stay due to genetic diagnosis, prematurity, or other congenital anomaly to Social Security for supplemental insurance. We also encourage parents to do their own research and to apply for grants, as there are many out there for NICU families. We're always available to write letters of recommendation. We screen for parental mental health. As we know, 1 in 5 women experience postpartum depression. Parents with a mental health history are at a higher risk for experiencing postpartum depression or anxiety disorders. Other risk factors include sleep deprivation, medical complications, and stressful events. NICU parents face a significant risk due to levels of stress. Having this information is helpful as we can connect parents with behavioral health and support services. This includes individual, couples, or family therapy, support groups, and parenting classes. The Hackensack Meridian Health Clinic now offers a maternal health program called the OB Well program, where parents are given 12 to 16 weeks of individual therapy. We also connect parents to other community partners, which include Care Plus, the Partnership for Maternal Health, or Postpartum International. Social support plays a crucial role in a family's ability to manage the stress of a NICU stay. Assessing whether families have a support network in place can help identify potential gaps where we can intervene, whether through connecting them with community resources or offering that emotional support. In addition to our community partners, we have a family support worker and a child life specialist assigned to the NICU to support our families.
I really appreciate all those points that Melissa brought, and we'll be revisiting some of them as we talk about implementation. And the next stop on our map is really thinking about after you've selected the tool and adapted it to the NICU context, how do you integrate this tool into the AMR And is this even important? And so I would argue that it is very important for a multitude of different reasons, or can be very important for a multitude of different reasons. But having a tool that's ingrained within your EMR can help to collect and track data on social risks and needs of a particular NICU population. And can really allow you to discern, hey, is transportation transportation insecurity much more common need than we had anticipated? Can we advocate for more resources, or do we need to build partnerships with different community-based organizations around transportation to help support our families? And so the collection and tracking of that information and the power of data by integrating these tools into the EMR can be really powerful. Streamlining, having a tool that is ingrained within the EMR can make the documentation of these assessments streamlined. Oftentimes the folks who are doing these in most units tends to be wonderful social workers. And so integrating this into the EMR in a way that is hopefully done to augment a pre-existing workflow for our social work colleagues, as opposed to adding something else onto their plate, can help to streamline that process. We talked about the downloading of resources as well. And lastly, to be able to, another benefit of embedding this information within the EMR is communicating the screening and referral information with the interdisciplinary team and outpatient providers. One of the things that commonly comes up with the qualitative research and some of the qualitative work that we have conducted as well, that there is at my previous institution, is that team members may not always be aware of what the folks who did the screening are aware of. And is there a way that this information can be demonstrated in a user-friendly format to all members of the interdisciplinary team, so that all members of the interdisciplinary team, including the bedside nurses and the social worker and the APP and the fellow and the attending and the respiratory therapist, so on and so forth, can have this information that's easily accessible to them, so that when these discussions come up at the bedside, there can be a greater awareness of, hey, does someone actually know about this? And has someone tried to help the family with this already? And if not, this is my opportunity to bring it up to someone who can help. This is an example within our own electronic medical record of what the what embedding this can look like in the EMR. This is something that is relatively newer to our interfaces here over the last couple of months. We use Epic here, and what you can see is both in the storyboard on the left-hand side, in addition to under the summary overview tab, that you have these graphics of whether an SDOH screening has been completed for this particular patient. This was a newer patient who had not yet had a screening performed, but depending on what system you use and how the information is put into the EMR and what flow sheets are used, what note templates are used, that information can auto-populate into these various different domains. Some of these domains are ones that we had talked about at the start of this presentation. And you can have information as to whether a domain was screened for, whether there was security within that domain, or whether there was any social need within that particular domain. And again, this is a simple graphic that members of the care team, all members of the care team should be able to look at and easily see, hey, a screening's been completed or not, and are there domains that a family has social risks in. And so practically, a few other hodgepodge of things to consider with the integrating these tools into the EMR. There's currently not, based on the research and what folks have published, there's not a consensus regarding the best way to document social risks and needs in the EMR. And so this can include scanning paper surveys into the EMR, manually entering the data into flow sheets, giving tablets to families, or pushing surveys out through a patient portal, and that gets auto-populated into the EMR. There's not a consensus as to what's better or not. And I think thinking about the staff that you have in your particular unit, the staff that we have in our particular unit, and what is feasible and most user-friendly for all team members to be aware of what's going on, those are things to consider, given that there is not one proven best way to do this. IT support. So of course, integrating these tools into the EMR takes a lot of IT support, and modifications to the EMR can take a very, 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 very long time. And so incorporating your IT folks early on in these discussions can be really, really beneficial and help streamline that process. And additionally, special considerations for the NICU is there opportunity to link the birthing parent chart to the infant chart? And so we have that available to us in Epic, and those charts typically are linked together. However, is there a way for that initial screening to perhaps auto-populate into the baby's chart, at least for that initial assessment? Because with the 2024 CMS mandate, our birthing parents oftentimes have that initial screen available to conducted already before the baby is admitted to the NICU.
Each patient must have an SCOH screen on every encounter. This is done by the unit social worker or case manager. We also work with the transitions of care specialists, which are staffed by the Department of Patient Safety and Quality. They screen uninsured, underinsured, and Medicaid patients and provide support for 30 days post-discharge. We often collaborate on patient needs. They assist with scheduling appointments, arranging transportation for outpatient visits, and have access to supplies such as blood pressure cuffs and breast pumps. The nurses on labor and delivery are responsible for entering the responses for intimate partner violence or on admission. Responses to the SCOH questions are entered into our EMR in a structured format to ensure consistent documentation and easy reporting. There are drop-down menus and checkboxes. Previous responses are viewable in the flow sheet. This is helpful as we can follow up on previously identified needs. This allows for all members of the interdisciplinary team to access the most up-to-date information and enables every member to provide patient-centered care.
So on our third stop on this journey, let's talk about electing referral resources. And so how do you, once you have the screen conducted and you have families who have unmet basic needs or social needs, and what are the resources, where are you going to find these resources? And so there are a few different ways to do this, and different units do it differently, and a couple of tools that are available that can be made available to families in the NICU team are twofold. One, resource guide. So a resource guide is typically defined as usually a one-page resource information handout, and I'll show you an example momentarily, for each screening domain. So for example, you can have a page on support for housing, you can have a page on support for employment, a page on support for transportation, or alternatively, you can have just one page that has multiple domains with local community resources and their contact information. And alternatively, resource aggregators are also available. They're paid versions that are oftentimes embedded within the EMR systems, and they're also free versions. And so a resource aggregator is really a platform, an online platform or search engine that compiles information about various SDOH resources and community-based organizations from multiple resources, making them accessible in one place, often with very powerful filtering capabilities. And so although both of these strategies can be quite helpful, what I would argue is that resource guides are really the bare minimum that we should be offering to families. And this can collate local and most frequently utilized resources that families can benefit from. Resource aggregators can be really powerful as a supplement to help tailor resources to families' geography, language preference, and other factors. If your catchment area is quite small, a resource guide might be helpful for your particular unit. And these resource guides are typically guides that are crafted by the NICU team, which admittedly does take intensive few months of preparation time. But if your catchment area is quite large and you have patients coming in from, a multi-state region, especially in the New York metropolitan region where families are coming from all over the place, resource aggregators can be really powerful and offering resources for families who may live far away, who would otherwise not benefit from the immediate local resources to your NICU. This is an example of a resource guide, and what you can see on this one-page sheet that I've blown up here is you have information about housing, you have information about transportation, information about food, and it's not 1,000 resources under each section. It's really 1 to 3 resources under each of these sections so that families are not overwhelmed, and has links, has QR codes that families can engage with. This is an example of our resource aggregator that we have available to us here, and this is, you can link this, this can be linked through the EMR. This is called Unite Us. And so essentially what you put here is if you have a family that has an identified social need, for example, housing insecurity or food insecurity, you can select that domain. You can select their address. You can select the distance from their address that you would like the particular resource to be available to this family. You can select a language that the family speaks that will connect them with community-based organizations where they offer interpretation services for that particular language. You can search for whether or not a particular community-based organization or resource has a fee for that particular service. And so as you can see, this can be very, 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 very powerful. And just in the sliver of a picture that you see here, there are, millions of patients, over a million families that live again in this New York, New Jersey metropolitan area. And so just in the sliver of a picture. And so the utility of having a resource aggregator for a geographically diverse patient population can be really, really, really powerful. In thinking about creating a resource guide, I really like this framework. Leverage existing resources, social workers, care managers, those who actually already refer families to various resources may have a bucket and toolkit of various resources that they already love and rely on. And these can be easy go-tos in creating a resource guide of initial resources. Oftentimes, social workers have built partnerships with these different community-based organizations and know that these community-based organizations have reliable intake and are actually able to connect with families after, that they actually care for infants and families as opposed to just adults, so on and so forth. So leverage your existing resources. Use resource aggregators to find new resources. Findhelp.org is an example of a free resource aggregator that is available to anyone. Call community resources to assess fit for NICU families and build partnerships before putting these resources on a sheet for families to utilize. Make choices about optimal community resources. And lastly, develop information sheets that are translated into commonly spoken languages within your unit. And lastly, for iteration and maintenance, get feedback from your families. Are families having success with these resources or are they not? And have a routine auditing process where every 6 months, every year, every 2 years, you're routinely auditing the resources that you have so that families can actually connect with the resources that they need.
As Dr. Kareem mentioned, at Hackensack, we utilize Unite Us, an online network of resources, which includes services on financial assistance, housing support, mental health services, educational programs. This program can be accessed in our EMR toolbar. This portal allows us to enter the patient's zip code and will populate a list of local resources that can be printed out or sent directly to the patient. Helpful resources I have found on Unite Us have been food, clothing, and diaper banks and rental assistance programs. Given our unique population, the pediatric social workers have compiled local resources that meet the needs of our population. These resources include programs that help new parents with baby supplies, mother and baby housing resources, perinatal therapists, and support groups.
So if you were to bring this to your unit, those are those 3 points on our map are oftentimes ones that should be strongly considered before bringing a particular screening or referral intervention to a unit. And so when actually implementing these interventions to a unit, what are the factors to consider? And so this is a little bit of a hodgepodge of various different things, a lot of which Melissa touched upon already. But there are a multitude of different stakeholders that are really important in these conversations. And so getting patients and families involved. You have a family advisory council that has diverse representation of your NICU families and parents. What was their experience like with unmet basic needs or met needs while they were in the NICU? What was their experience like with connecting with community-based organizations? And is there a way to get them involved early on in these conversations as folks are bringing standardized screening and referral interventions to their units? Social workers who are really the experts in doing this work, who've been doing this for, as long as the field of social work has existed, really leveraging the expertise and being able to standardize these workflows and processes. The interdisciplinary team, if your unit or your academic institution or your hospital has a division of community and population health, partner with them because pre-existing workflows may already exist for the outpatient setting that can be adapted to the inpatient setting. Our obstetric colleagues who care for our birthing parents before they birth the infants that we care for in the NICU, and with the 2024 CMS mandate, whose teams are conducting this inpatient screening before infants are even born. Outpatient pediatricians, we oftentimes neglect to consider the relaying of unmet basic needs to outpatient pediatricians, and can we leverage these standardized processes and workflows and the EMR to ensure that families know not only what happened in the NICU, but what are the social needs that families have on discharge from the NICU, and lastly, community-based organizations as well. A few questions that come up oftentimes: who should do these screenings? And so there's not one universal standard, and different places do it different ways. The survey study that I showed you earlier, the plurality of responses from that survey demonstrated that social workers were the most common um, individual among the NICU staff who performed these standardized screening and referral interventions, oftentimes because they're already trained in doing this work and are knowledgeable of assessment of social risks and needs and additional resources that may be available. However, differing units have differing degrees of support from a social work staff, and social workers, of course, are busy and have multiple competing priority needs. And so that is certainly something to consider. Something that came up from the folks up in Boston is they did share that sometimes social workers, that certain families in the NICU had certain relationships with social workers in that particular unit, where they feared that if they had disclosed unmet basic needs, that their children would be taken away from them. So although that's not a common story, that is certainly one that exists out there. So certainly something to consider. In other units, bedside nurses who develop really beautiful longitudinal relationships with families and are already aware of families' social needs were the ones to conduct standardized screenings. Of course, nurses are quite busy and have multiple priorities in caring for critically ill infants. Advanced practice providers, trainees who oftentimes turn over every 2 to 4 weeks and need to be retrained. Although there's significant motivation by trainees, and as these this education has been sort of launched into med schools, there's a lot of enthusiasm from trainees, but the training can be quite extensive every 2 to 4 weeks to develop uh, staff who are trained in doing this work. Peer navigators are folks who are sometimes outside of the direct NICU staff, who have training in doing this work, can be used. But again, this is quite rare in NICUs. And lastly, a person might not be doing the screening. This could be a survey that is pushed out via patient portal or is administered via tablet by a multitude of different personnel to families. When to do the screenings. Melissa touched upon this, and oftentimes screening families earlier can allow sufficient time to connect families with resources during what may be a very prolonged hospitalization, or not. It could be a short hospitalization as well. And so being able to identify those needs early on in the hospital course can be important, of course, while balancing the fact that children may be critically ill when they're admitted to the NICU, and that families may be thinking about whether or not their infants are actually going to make it or not, and how could we be sensitive and, again, think about a trauma-informed care approach in doing these screenings with families, so that we're doing it in a way that truly supports families as much as possible, as early as thoughtfully possible. How many times should you be doing the screening? And so this is a little bit of an area of debate, mostly because there's not a lot of research and information out there. Do you do this once, which is less resource intensive? You are doing the screening and identifying potential unmet basic needs and connecting families with resources. But as we all know and have experienced, families may develop multiple unmet basic needs, especially over prolonged NICU hospitalization, especially our most vulnerable families and infants who are the most preterm and oftentimes in the NICU for the longest amount of time. And so we don't know what the acceptability by families is of repeated screening. The reason I highlighted this in green is I think for a multitude of different reasons, both for us to learn really to be able to capture potential unmet basic needs that are evolving over time. Screening more than once may be helpful to really support our most vulnerable families. Handling positive screens. So if you've identified an unmet basic need, what do you do with that? And so these are this table is from Vaughn, and what the folks here are recommending if the screener is done by social worker, that processes should be developed to make the NICU team aware, because that social worker will oftentimes then will refer families to different resources and may actually see whether families actually engage and connect with those resources, which I think is really the pie in the sky, what we're hoping to see. However, if the screening staff is someone who's not the social worker, then a process should be created at that particular unit where positive screens are communicated with social workers for follow-up. And depending on what that unmet basic need is for a particular family, some of those needs might be more urgent than others. For example, housing insecurity or food insecurity might be more urgent and a much more pressing concern that needs to be raised to someone who can help families with those needs more urgently than something such as employment or education desires for a family, which is incredibly important, but may not be an emergent need. And interdisciplinary rounds within a particular unit may be a time when those needs are discussed that are less pressing. And so again, this can look like a multitude of different ways in different places. Peer navigators or community health workers sometimes are the folks who help to ensure that families are connected with resources. So after you've made the initial referral, how do we know that that referral was taken advantage of? How do we know that a family was actually able to get resources? And so that portion is oftentimes the most time-consuming portion. And not all units have a way of ensuring that families have actually connected with those resources. But peer navigators are sometimes folks that really more prominently exist in the outpatient setting, where if a family is identified as having social risk or social needs, that they are folks who can longitudinally, even after that visit, assess whether or not families were able to engage with those resources and to provide ongoing referrals for new unmet basic needs. And at the Minneapolis Fawn Conference just this week, one unit shared a model in which they had a parent partner who offered lactation support, who was trained in peer navigation, who was able to do this within their own unit without having to bring anyone from outside the unit. And lastly, that really pertains to following up the referral. So I won't go on too much about this, but Melissa will share a little bit about this in just a moment. And again, there are a multitude of different ways, but what resources do you have available to you? Can you make a pitch to your hospital for being able to have funding, whether it's grant funding or hospital funding, for a peer navigator that can follow these resources in a longitudinal way? Or are you going to rely more so on the social workers who already exist in your unit and the creation of resource guides for your particular unit? And so, in putting this all together, what does this look like on the ground? This is an example, as we finish up just in the next couple of minutes, of NICU workflow integration of a standardized screening and referral interventions. And so this was published in 2023 in Pediatrics, again, by the group in Boston who's championed a lot of this work within neonatology. But what the team here decided to do was to screen only families who are going to be in the NICU for greater than or equal to 1 week, with the idea that this would lessen the burden on the staff that is performing these screenings, and two, that the patients who are there for less than 1 week are likely being screened by their pediatricians in short proximity from their birth. And so once the screener has determined that eligibility, and here this was nursing staff that did the screenings, that the screening would then occur within the first 2 weeks of admission using the Thrive screening tool that I showed you earlier in a structured conversation format. After that screening is conducted, the screener then elicits a family's desire for assistance. So after you've identified unmet basic needs, you ask permission or you ask a family's desire for being actually connected with resources for particular social risks. Then a resource guide is generated in the EHR using a smart phrase that can be printed out and given to the family. That screener, again, who's not a social worker here, they then relay the urgent unmet needs, such as being unhoused, to social workers via a page, and less urgent needs are then discussed weekly during social work rounds. And lastly, with this workflow, social workers follow up with family and help to troubleshoot barriers, again, to ensure that they're actually connecting with resources. And really, as we are, and you know, if you're using quality improvement methodology to do this work, and one of the things that is really important is thinking about how to utilize equity-focused quality improvement work, and to examine social risk screening by different social factors of interest, such as race, ethnicity, and language preference, so on and so forth. EFQI really has many, many principles, including the inclusion of families and community partners as stakeholders in these workflows, identification and naming of root causes of inequities, focusing on systems, not individuals. But one of the really prominent tenets of EFQI is the stratification of sociodemographic data and intentional comparator groups. And so the reason I highlighted this is if you're implementing multiple PDSA cycles, Oftentimes your run charts look like the figure in letter A, where you have your outcomes tracked longitudinally with different PDSA cycles with your cohort at large. However, something that could be interesting and really helpful is really disaggregating that data by various sociodemographic characteristics of interest, whether that is race, whether that is ethnicity, whether that is preferred language other than English, to see, hey, are we actually helping all groups in the same way? Are we actually helping to narrow disparity whereby in figure D, what you see is that among the most advantaged group, who's the line at the top, and the most disadvantaged group, who's at the bottom, that outcomes are improving among all groups, but that gap between the two, so the disparity between the most advantaged and the least advantaged, is actually narrowing. When some of these other figures, although outcomes are improving for all groups, that difference between the most advantaged and least advantaged is staying the same, and so in turn not a reduction in the actual disparity.
When conducting SDOH screens, it's important to approach families with empathy and respect. These questions may feel intrusive, so we must make it clear that it is about supporting them and not judging their situation. It's critical to assure families that this information is confidential and that our goal is to help connect them to resources. This can be done by building rapport and trust. We can do this by offering a safe environment that allows parents to feel like active members of the team and empowering them by encouraging exploration and asking open questions. By identifying these challenges early in a baby's NICU journey, we can intervene proactively to reduce the risk of these negative outcomes. Families who have their basic needs met are better equipped to focus on their baby's health and development. We have had families in our NICU facing homelessness, food insecurity, domestic violence, substance abuse, and familial deaths. While social workers are typically the ones who conduct the screenings, it's vital for the entire NICU team to be involved in supporting these efforts. Physicians, nurses, and other healthcare providers can help by bringing up concerns they may have about a family's social situation. It's important to maintain an open line of communication between all team members to ensure a holistic approach to care. The person is complex with complex needs, and all parts need to be functioning. Ongoing communication allows us to coordinate care effectively and to ensure that there is appropriate follow-up to referrals. We find that multidisciplinary rounds is a great opportunity for this. MDR has been helpful with getting important updates, such as if a parent is struggling with a diagnosis or hasn't been involved in care. Sometimes parents have a hard time navigating resources we have previously provided and require further assistance. There are things that we may not be aware of due to the patient to social work ratio, and since we are not at bedside 24/7. Some considerations are time restraints. There are many needs, however, it can be difficult to manage with the patient to social work ratio and depending on the census. Some patients are only briefly admitted to the NICU. For longer stay parents, their schedules must fit into their other roles and responsibilities, as many families have one or two working parents or older children they must care for. Parents may also be hesitant to discuss sensitive issues. And finally, there is a limited availability of community resources. In conclusion, addressing social determinants of health is an essential part of neonatal care. By identifying and addressing these factors, we can help improve both short-term and long-term outcomes for our babies and their families. I encourage everyone to keep SDOH in mind when working with families in the NICU and to refer them to your social work team if you believe there may be an unmet need. Together, as an interdisciplinary team, we can ensure that every baby has the best possible chance for a healthy future, both inside and outside the hospital.
I think Melissa really wrapped up our conclusions really, really, really beautifully. And again, it takes a village to be able to bring this to a particular unit. There's no one perfect way to do it. And you have to adapt workflows and processes to your particular unit, your particular staff, and what resources you have available to yourself. And again, it's not about just doing this, it's about doing this well with families being centered in this work and including these families as partners in the creation of these workflows and also assess using family-centered metrics to assess your work as well. And I wanted to really wrap up with this quote that has resonated with me ever since I read it, but really it is our responsibility to follow through, as Dr. Prophet had talked about, and address the social determinants of health with the same energy and expertise that we devote to the technical aspects of the care that we provide, because we know that these have just as important of an impact on the longitudinal health of our patients and families.
Thank you so much. Tremendous topic with wide-ranging impact, what it takes our families to show up at the bedside, what they have to navigate, the screenings that you refer to, and the support that we can provide, to help them in doing that is, I think, really key to the care that we provide. So we are going to transition now. Terry's going to launch with some of the questions from the chat.
Hi, thank you so much, Kaisa and Melissa, for sharing your work that you've done and bringing that to all of us. So the first question in the chat, have there been any programs or evidence to support research that's been done that you're aware of for the potential opportunities during a NICU stay to help women adopt healthier eating behaviors for themselves and their children?
So that's a really, really good question. And I think in one of the frameworks that was really helpful in thinking about this for me, at least, is the framework from the folks at Boston, where you looked at the microenvironmental factors and the macroenvironmental factors. And that is an example of something that is important in the microenvironmental factor. And there certainly has been research. I don't know if in the NICU, but certainly in inpatient pediatric environments that have looked at that information. And I'm not aware of specifically, I can't recall the data. And I think thinking about it from a macro environmental perspective, one of the questions that we need to ask is, do families even have access to that nutritional food? And so oftentimes we find that the counseling that is given to families, both in inpatient and outpatient settings, oftentimes with pediatric settings and also OB settings, so adult counseling, that oftentimes a rate limiting step for our most minoritized or lower income families is the actual access to those resources. And so what is the counseling you're offering? I think is a very, very important question. How does that impact outcomes? And then thinking about it from an SDOH perspective and the macro environmental factors, what is the access to healthy, nutritious foods that families may have in their community or not have in their community? And how can we connect those families with those resources so that they can enact the counseling or the micro environmental factors that they have received? Anything to add, Melissa? Okay.
Thank you.
Another question that was in the chat was about for the social determinants of health, is a single parent status included in that social determinant?
Go ahead, Melissa. I see you not.
Sure, yeah, this is a question that we also screen for, what the family structure looks like if they are living with a partner, if they're married, divorced. We discussed how social support does have a crucial role in how families cope with NICU admission. So we do ask this question, yes.
There's evidence in the research about sort of looking at short-term and longer-term health outcomes in addition to sort of parental stress, anxiety, postpartum depression, by whether there is a second parent or not a second parent, and also other support structures. So even if it is a single parent, what do the other support structures look like? And so language proficiency, access to employment, access to healthy food, and social support being the family structure, and also social and other non-familial social support can all be thought about as social determinants of health.
Thank you. I want to thank our participants for being with us today. I want to thank our panelists and invite you to come back on camera so we can see your faces again before I transition into our wrap up and important next steps. So a profound and genuine thanks to everyone who made this day possible. I know from beginning to end, there have been pearls that I have gathered from each and every one of our speakers, things that I'm like, oh my goodness, I'm guilty of this. I'm going to do better. So at this part of the program, which I think is actually one of the most exciting parts of the program, something that I thought about as we were putting this conference together. And that was something similar to what Mary said is, I'm going to just paraphrase, I think she said the best way to eat an elephant or a whale was just one bite at a time. So when you take a step back and look at all the challenges that we are faced with as care team members, as families, who are also part of the care team in the NICU, and getting our patients through their journey, it can feel overwhelming. But if we take that one bite at a time, then we can make tremendous change. So, as part of this program, you will all receive, of course, a post-event survey with the opportunity to give us feedback. But what I think is really special and important is that you'll have the opportunity to participate in facilitated trauma-informed care, health equity, quality improvement projects. What do I mean by this? Each of you within your own environments are going to be asked to take a look around and identify one thing that you would like to see done differently at your institution. You will then be able to participate in 3-hour-long facilitated sessions where other participants and multidisciplinary, when I look at the over 200 people that were on the call, I saw respiratory therapists, I saw child life specialists, I saw nurses, I saw physicians, I saw parents, I saw people from March of Dimes on the call today. So you, the participants, will make up this cohort that will give feedback to workers who are there every day trying to improve the lives of patients in the NICU, and you'll be able to give feedback. Our panelists are contributing a list of references and tools that you'll be able to use in these sessions. So over the next 3 months, so that's March, April, and May, you'll come together for 1 hour and talk through your ideas, talk through some of the tools that we received today, talk through some of the references that were included as part of our tools, and begin to shape a quality improvement project for your home centers. Then in June, specifically on Friday, June 13th, we'll come together for a summit where each of you each of the cohorts will select a project within their group that they think is exemplary of trauma-informed care and health equity in the NICU setting, a quality improvement project, and select those to be heard about at our summit. So we all come together to learn about some of the work that's being proposed at various centers, and also to give feedback to those projects as well. In June, we are hoping for better weather here in the Northeast. This summit will occur at our Center for Research Discovery and Innovation. And of course, because of the world that we live in now, there will be a hybrid component so that participants can, participate no matter where they are in the world. And so I think this is a really exciting opportunity made possible by funding from the American Academy of Pediatrics, District 3, section on neonatal perinatal medicine. So a big thank you to them today for making this possible, and certainly made possible by all of the knowledge imparted by our tremendous panelists and speakers today. So look out for the survey, and I look forward to hearing from you and hearing about the bites that you've taken out of that whale in terms of moving the needle forward. This includes the formal part of our program. We'll stick around for just a few minutes for any last minute question to our panelists who were with us today. Thank you. And there's one question in the chat regarding getting CME and CEU credits. So you will receive a survey today, and in that there will be instructions for claiming your continuing education credits. And just as a reminder, you'll receive credit for attending any live time. We are not able to provide credits for those who watch a recorded event. Any comments from our speaker panel or questions from our speaker panel?
Dr. Island, again, I was, as I was listening to the other panelists and reports and presentations, I do want to emphasize what the importance of those family supports, the village outside when you have a couple dealing with something like this. One thing I didn't share was the example for us. My wife is a member of one of the Divine Nine sororities, and she was her sorority made sure that we had food every day. We would come back every day after coming from the NICU. This is in the early part of the journey, and there'd be a cooler full of outside our door full of you know, casseroles and things like that that we could quickly heat up. And I share that because that and the extended family support is a key component. And I heard parts, references of that throughout today's presentation, but I can't overemphasize that those pieces. And I'd also want to really thank Dr. Karim and Melissa for the work, the social, that component, that wraparound that people need is so important in getting through these type of journeys. So I just wanted to thank you all for that. And again, it's just an absolute privilege to be part of this esteemed panel.
A question for the parents on the panel. As a NICU parent, what is the one thing you wish the caregiver team knew?
Dr. Island, there's so many pieces there. I do think that and I do apologize, there's a little bit of noise in the background. One of the little ones just came in from school. Um, I do think that the getting to know the family as quickly as possible is really key. Um, and at least for us, that was, and there was that moment of when you connected with a nurse or a doctor, and it was beyond just the clinical, the technical of what was going on. Um, is so critical in that early part, and so the providers need to. I think everybody does that. I hope they do, but it's key. It's key. It was key for us in establishing the relationship with the variety of people that we began to see regularly through our journey, and that to this day we are still in text contact with all of the nurses that were part of our journey. So I that's critical. I would say. I don't know. I'm sure Kimberly has definitely something to add. I would love to hear what she has to say too.
Yeah, it's a tough question. I agree. I think there are so many things. But I think, as a parent of a child that died, I would say the importance of giving families time and space to sit with and accept difficult diagnoses, or to be able to accept when you've reached the end of all that you can do. I think that a lot of times what people forget is these may be things that you're dealing with every day or may just be a Friday for you. But for us, it's our whole entire life, right? And it's the future of our lives. And so a lot of times what we're contending with is having to make another dream for our family when we realize that that first dream is not going to materialize. And so it takes a lot to be able to accept that, to come to accept that, and decide, how am I going to make it out of here? How am I going to live? How am I going to wake up the next day and shower and take care of myself and be okay? And so, when there are decisions that have to be made, as was with the case with my son, once you've put the information out there, let me sit with it, let me get used to it. Don't ask me again the next day and the next day and the next day about what it is that we're going to do. As a parent, I have to prepare my heart for what happens next.
I just concur with Kimberly, and Kimberly, my heart goes out to you. In I cannot tell you how incredibly aware I am each day of the journey that we could have walked. And I just was telling a colleague, like I don't, I know we're very blessed, but but I'm also, thinking from an American, we were very lucky that we had the outcomes that we had. And I agree with you that space, sometimes the emotional intelligence is important to recognize that the body language, sometimes people are really dealing with, again, the dream that is going to be different. And not necessarily what you had hoped for, and trying to find your way in that. So thank you, Kimberly, for sharing so much. Again, thank you.
Thank you. And I want to thank you all too for allowing me to lend my voice to this conversation, because a lot of times what we see is that, people love the miracle stories and they love the look at them now. And I do too, certainly. But we can't forget that quite a lot of people, particularly Black women and Black babies that experience prematurity, are not going to walk out of the NICU. And so it's still a valuable story that needs to be shared, and that needs to be given a safe space to talk about their experience as well. When a baby dies, it doesn't mean that you're not taking a loss like the family, or it's not that you didn't win, right? One thing that I've come to accept is that there are limitations to medicine and no one is to blame. Is that, we really just are not in charge of life or death.
Thank you.
I agree. Yeah, I can really just that. Yeah, that's Dr. Island. That going back to that early question of what do people, is like, you're not in control of this. The doctors are not in control of the nurses. You really are. Again, if you believe in a higher power, uh, there are moments where you are just leaning on that, because there is, it's not up to us to make that, to say what the outcome is going to be, and living with that acceptance, that possibility, is where I think the families need the greatest support. in whatever way that is, pastoral care, chaplain, all of those, it's all important because if you come from like someone like I'd say we were very privileged. We were very privileged. Was looking at the wheel of the SDOH wheel, and none of those issues were ours. All right. So I'm speaking from a place of great privilege, and recognize that. But those who don't have all of those wheels, all of those components, the journey is so much harder for them. And so being mindful of that, I loved Kimberly, you're saying not being judgmental of people and their situation is incredibly important, a takeaway from this as well.
I think that just really highlights the incredible relevance of compassionate collaborative relationships. I mean, Kimberly, when you talked about the 3 E's, I mean, it was just so profound that, in recognizing that we're not really in control of this, that we're all navigating this together. I think, or I hope, gives us the freedom to like drop the facade and just reconnect with our humanity, with each other, and just, I don't know, now I've lost my words, but just really lean into the opportunities as clinicians that we have to really help another person navigate an incredible crisis with love, without judgment, with all the good things that I think I know we have it in us. We just have to, drop that facade and let go of all the crazy stuff that we think is part of, being a professional and all that kind of stuff, just really lean into it. It's been such a privilege to listen to these stories and be part of this. Thank you so much, you guys.
Thank you again. As you say, it is a privilege to have been in this group, this community today, the sacred space that Daryl talks about. I want to encourage you all to take this feeling of hope, of change, of possibility, and take it to the next level at your institution to be able to support those patients and families that we are privileged to encounter. So with that, my most heartfelt gratitude to the panelists and to the participants. I'm thanking you in advance for the work that you're going to carry to your institutions and wishing you all a safe and blessed remainder of your day. Thank you.